Good evening, everyone. So this is Pictures and You, Module 2, CT Brain. So the main objective of this was to inculcate the habit and also the knowledge of interpreting CT images for undergraduate students. So this was just a plan which came into my mind and I wanted to implement it. So this is one of my few steps to reach that goal. Let's move on. So this is just for safety purpose of mine since I'll be streaming it in YouTube. Fine. Yeah. So initially, this project was planned for three modules. First one was chest X-ray, which happened on September of 18, which is 2 months ago. Now this is the second one. Sorry that I didn't change the poster date. So the new is today. So module three, it's tentatively titled for obstetric ultrasound and E-fast. However, I've reduced it to E-fast. You would have a surprise question for regarding which course to choose in your post-event form. So since I need your input also in choosing which module will be better for you. Fine. So let's go on with the action plan of today. So what all we are going to see. First, I'm just dividing into simply into just four components. What, why, how, and the application of today's class. So let's go with the what component. So let's go with the principle of how the CT works. So in simplest terms, CT is like X-ray but in 3D form. I can show you this picture. You can see this image, right? So the patient is just in supine position, sleeping up. So this is the CT scan machine, and it has rotating detectors and the X-ray sources. I took it from a article. So regarding how this CT works. So again, the CT is nothing but X-ray, but in 3D form. So what they really do is when the patient is sleeping here, so there are two types of motion in our world. Basically, translation, which is moving in straight from one point to another, and rotation is just moving across against an axis. So here we have two types of motion: translation as well as rotation. So, excuse me, sorry for the. Yeah. So this is how the CT scan works. So the patient is sleeping here. The drum, which is situated here in this part, sends out X-ray beam to supposing we will be having detectors. So it will be doing a lot of circles, and wherever it's feeling the obstruction, the rays will be detected and will be made into waveforms. This should be later interpreted in the form of walk cells. Let me show you. Walk cells are nothing but volumetric cells. You can just split it up. Pixel is picture cells, walk cell is volume cells. So these are this 3D 3D cubes which hold the data, whether from 0 to 1, where 0 is like it will be interpreted as white and 1 will be interpreted as black. And we can play with these numbers to get the necessary special features of the CT. Any doubt for now? Yeah. So the principle. So if anyone of you love physics, then this could be helpful. This slide would be helpful for you. So the basic concept is we'd be heating the cathode. We'll be having cathode and anode. So this is cathode ray tube. So we'll be heating the cathode. So the electrons get excited and it will hit over the nucleus of heavy metals. So what they happen is not every collision is elastic collision. Like 100% energy is not transferred into the other electron. So some energies would be dispersed. So one of these peak waves are called Bremsstrahlung radiation. So these Bremsstrahlung radiations are absorbed by the detector. So these won't also have how to say complete penetration. So penetration has proportionality over the amount of radiation it is left out across the body. So if the object is very dense, so less radiation would be produced and vice versa. So these would be captured by the detector and we would get the image. So coming to the same picture here, as you can see here. So the first motion is translation. So moving in one direction. So every data which we could collect, these are the three objects. And when the rays or X-rays are passed, this would obstruct it, thus producing a darker image. And here it's bright. So it creates a waveform like this. So this is just information, basic information which is stored temporarily stored in the computer for for fraction of seconds. So followed by that, what happens is we will also have rotation components. What we do is just do the same translation process, but in different axes, sorry, different angles. So finally, it will make a complete 360 rotation and it will move forward. So initially, there are two types, where the CT machine would do a complete rotation, move forward, complete rotation, move forward. But in modern CT machines, it uses a helical pattern. So it will translate as well as rotate. It has multiple detectors, so it can do everything. There are other few concepts like back projection and front projection, which determines the quality of the images, but I think it's not necessary for today's class, since it's all about interpretation rather than getting to know much about it. All right. Any doubts so far? Please put up a thumbs up if you're if we shall continue. Again, please feel free to ask any form of doubts. Just unmute yourself and ask questions. No worries. Can you repeat the white and black part? Yeah, sure. So imagine these things as a body which is less dense and bodies which is more dense. So the translation, so striking beam and a single angle, let's say this is zero angle something. So for its density, it will obstruct some part. Since this is more dense, white is more dense, it will obstruct most of the part. So we are getting a dip here. So, wait a minute. So this maximum, the crest of the wave, let's consider it to be like any number, which is 0 or 1. So usually density, since this is less dense, let's put it in the area of 0. So we can put complete black as 0 and complete how to say complete dense as 1, complete white as 1. So this would produce as somewhere near to 0. This is somewhere near to 1 and 0. So this waveform is generated. So this is one information. Now these informations are taken in multiple angles. Oh, wait a minute. Okay. Yeah, I need to disable the gestures in Firefox, I guess. Yeah. So here we can see first it will do translations, followed by it will simultaneously rotate in every angle, and it will move forward in a helical pattern. And since we need to move it axially, this is a big machine. It cannot move on itself, right? So we have a moving platform. This moving platform go in. So by relative motion, it feels as if it's going in this. This detector machine goes forward. Fine. Is the doubt clear, Tanya? Yeah. Okay. Thanks. Oh, that's a clap emoji. It's the first time I'm seeing it in Zoom. Fine. So coming to projections. So what are the possible projections? What are the possible directions which we can use, which we can take CT? Since it's a 3D form of X-ray, we can take in all the three dimensions. So which are axial, coronal, and sagittal. Axial is the most common. And in USA, instead of CT scan, they say it as CAT scan. So yeah, CAT scan is computed axial tomography. That's it. Here in British literature, it's just given CT scan. Fine. So what are the indications? So this is the main thing which we need to see here. So one of the takeaway points. So any acute head case, X is just a variable. So any acute head symptom is coming to our hospital in India, at least in India, your first modality is to use CT. That's the first thing to do. In our hospitals, we used to call it as NCCT, which is non-contrast computed tomography. I'll be talking about that later. Yeah. So axial. So this is the most commonly used projection. So this is by the default projection. So coronal sagittal is used only in special cases, like here in coronal. Yeah, if you want to see a deeper aspect of brain, like if you want to see the white matters here, or other white matter tracts and gray matters here, so we can take a coronal section. And if you want to see any midline deviation or etc., we can also appreciate better in coronal. Yeah, and sagittal is the most commonly used for midline structures because if we get into the exact half area of the brain, then we can appreciate all the midline structures here. So by scrolling up, by scrolling to the left or right, we can see the depth from which it is come. The lesion is from the midline. I hope we can imagine better. So if something is more towards the right, we can appreciate in axial itself. But if we want to confirm much better, or if there's any, how to say, bleeding, let's say here, this is pons. I hope everyone knows anatomy. Who are all first years here? Please raise your hands. Okay, Tanya. Okay, that's great. So I hope you know what is pons. You have read in for your NEET UG also. So this area is called prepontine system. So this is a CSF area where cerebrospinal fluid is there. If there is blood collection, we cannot much appreciate in axial. We can, but you need to have, how to say, an eagle's eye or something. And if you want to, how to say, appreciate very minute amount of blood, then we can take sagittal because prepontine system is located in the midline area. Fine. This is next one. Yeah. So I have given a link here, which is AC Search uh, website. So this is because there are various, how to say, pathologies which we are aware of in our and which we will learn in our, how to say, future medical life. So each of them has each criteria to which we need to use CT. For example, let's say we are suspecting any, how to say, metastasis. I hope you know what is metastasis, right? So if you have a cancer in some place, and these cancer cells tend to migrate if they are migrating to brain, let's say. So there are some criteria, there are some points where you need to note that at what point of time I must suspect these things and I must use CT. Or what point of time I must ignore CT and go directly to MRI. Or at what point of time CT is not even necessary. You can just clinically diagnose it or something. Yeah, is it fine? So the take home of this slide is any acute head symptom in India, start with the CT. Now, why CT? Why not MRI? So these are the advantage and these are the basic advantages and disadvantages of CT when it compared to MRI. So the main advantage is it is quick and cheap. So you can you saw the CT machine, right? So it looks as if it takes a lot of time. However, it's much more faster than MRI. Since the X-ray source and detector rotates in how to say, mm, it was about somewhere around 1 to 2 degrees, 1 to 2 degrees per second. So which is significantly faster compared to MRI. What's the time, you know? Actually, you had raised your hand. Oh, okay. Is that for the first year question? Okay, sorry for that. Sorry for that. I hope it's for that. Okay, fine. Yeah. So second is cheap. And of course, since India is a developing country, at least according to the World Bank, so CT is much more accessible for all the patients here. Third one is when compared to MRI, CT is better to find bleeding. It's because MRI is magnetic resonance imaging. Its basic principle is just taking water molecules. This is the simplest way to describe MRI's principle. You just uh, use high magnetic field So what it makes is it makes the water molecules vibrate. So these would give a high resolution images. However, bleeding is very hard to figure out because the brain has how to say, it's mostly made up of water, right? Water and some amount of fats and proteins, right? So it's majorly made up of water. So and so is blood. So what happens is it's you would be unable to differentiate better between blood and brain parenchyma. Parenchyma is the brain tissue. So CT is much better in figuring that out. And the last one is metal objects can be used in CT. And if you are using like pacemakers or let's say even simplest things like nose piercing or etc., in MRI it will just rip you off. You don't want to happen, I hope so. So CT is much better when we are using any metal objects or pacemakers, etc. Especially because pacemakers are electrical devices, right? So magnetic fields can interfere with it, and we don't want to risk the patient's life, right? So the disadvantage of CT is it has say less resolution compared to MRI. As I told you, it mostly it is based on X-ray. X-ray, how much is absorbed, how much is emitted, right? So MRI is based on water molecules vibration. So you can make every water molecules vibrate, but you cannot make every X-rays pass through every objects in the brain. Sometimes, so the resolution would be comparatively poor other than when compared to MRI. There are various ways where you can increase the resolution of CT, which I told you, like back projection. I told you 2 slides ago that it's much ahead of the scope of today's class. Yeah, so there's some technique called back projection, and also other techniques like if you can, how to say, make the slices more thin. So CT is like every images would be in the form of slices. So like a loaf of bread. So if you are thinning the slices, then also you can increase the resolution. However, yeah, so there'll be a lot of how to say hit on the resolution when if you want to identify some lesions in the precise locations. And say next one is little special modifications. MRI has lot of modifications like there's T1 weightage. There's something called weighting in MRI. So there are the modalities like T1 weighting, T2 weighting, and other things like functional MRI. Functional MRI is growing very fast in current technological world. And we also have something like MRI flare. Flare is used to just it's like minus CSF. If you want to completely remove CSF in the picture so that I can see the brain tissue clearly, then you can something called MRI flare, etc. So there are a lot of special modifications. However, there are very few in CT. So one is non-contrast. Next is using contrast enhancement. So we'll be administrating intravenous contrast. So contrast is like a dye. So it's a radiographic dye which you're injecting through the veins of the patient. So, and in a particular time window, you need to scan the patient so that you can see enhancing. Enhancing is like how to say brightened up images in the CT, right? Fine. And also there's something called CT angiography. CT angiography we use when our NCCT, our non-contrast CT, is not quite conclusive of any results when we are suspecting any stroke or something. If you're suspecting any bleeding disorder or any stroke or something, but NCCT is not quite how to say giving a precise answer for us, then we can use CT angiography and look for where the how to say obstruction in the vessel is in the artery. Fine. Any doubt for now? These are just basics. We need to ascend more much above. There are a lot of things to cover today, I guess. So, shall I proceed with it? Yeah. If I could proceed, please put a thumbs up. If you have any doubt, raise your hand. There's a reaction softening zone. Yeah, fine. Great. Moving on. So before dealing with the class proper, I want to just show you this golden rules. So this golden rules is not specific for CT per se. It's for everything when it comes to radiology. So these were most of the golden rules were. Can you have a note on PET-CT? Yeah. So PET-CT is positron emission tomography. So it's again a radiological modality. It's primarily used to look for any active cells. So active cells in the cells, let's say if there's any infection of if there's any tumor. So normally there are many cells in our body which has a normal, how to say, metabolic rate, right? So it produces some amount of glucose and its metabolites. So when it comes to infections or any tumors, so they are very much active. These cells are very much active. They're trying to, how to say, they're striving to live, right? So what happens is the tumors are much more active. So they utilize more glucose. They utilize more glucose, and in infection case also they utilize a lot of glucose. So this these active tissues are found out specifically by PET-CT. So that's the prime use of PET-CT. I hope it cleared your doubts, I guess, sir. Yeah. So NCCT and CECT is just you can get to know about where the blood is flowing, where the blood is not much flowing. However, PET-CT just gives an idea that which tissue, which part of tissue is much more active in metabolic processes. That's it. Yeah. So coming to golden rules, so some of these rules were set to me by my seniors, and some were written by myself. So these are the rules to follow. First one and the last one are the most important in this. First is say what you see. So if you are given any radiological image, don't just assume that this could be the most likely thing. You just go through every aspect of the image provided, look for every areas to consider, and finally just say whatever positive or negative findings you see. That's it. Because let's say if you are assuming a diagnosis to be X, let's say. So what would you might do is there's something called confirmatory bias. This which is my second point. So in which what you do is you fix your answer in your head and you look for clues which would match for your answers. Like if you suspect for let's say any tumor in the head, you would just look for any how to say growth in the head, but you might even miss out small bleeding, or even it could have been completely normal. You would have seen some how to say small gray area, and you're told it's just a mild swelling or something. So this is the first point. Say what you see, and no confirmatory bias. Third one is imaging is only a diagnostic tool, not a one-stop solution. Again, imaging you cannot this gives an how to say emphasis on history and examination for every patient. We cannot just send every patient, I want to do CT for him, just do it. We'll get a lot of information, we can just completely solve this case, etc. and prepare for management early. No, that's not the case. So usually, my professors used to say 80 to 90% of diagnoses are usually brought about by history and examination. So this third and fourth rule gives emphasis for that. The fifth one is physicians are physicians, radiologists are radiologists. So this provides an insight on the respect we need to give to radiologist. Just by this class is intended to give you basic interpretations of CT brain, right? So I don't want to get into a lot of advanced things. There are multiple things. I refer to a lot of standard books, and they're given a multitude of how to say points to cover. However, radiologists have much more knowledge than us, and we should not. And yeah, it's my suggestion. We should never try to how to say go one step further than that, because there's a high chance that we might make a lot of mistakes due to lack of knowledge compared to others, compared to the radiologists. And the second last rule is always feel free to seek help from the experienced. Never feel shy or afraid to get to how to say your insights, clear your doubts from your seniors and other radiologists, even technicians. There are a lot of radiology technicians who are much more well versatile than us. So don't feel how to say that. ego or fear or self-doubt, etc. Just go for it and they will definitely teach you. And if they don't teach much properly, then ask different senior. Don't just go to by your conclusions and just stop your quest for knowledge, right? And the last rule is believe in yourself. This is, I think, the probably the most important rule here, because what we do is we see for the lesions, we might even look for have a correct idea about this is the how to say problem in the brain. However, due to self-doubt, we might even ignore it. Like this could be a normal finding. Why need to say to my senior, etc. Please say to them. That's it. Just believe your eyes and your mind. Yeah. Let me go to the next slide. Yeah. So I scouted across the internet to find the various systematic approaches for CT brain interpretation, and I was able to find out these three. These were the most common things. The most common here is the blood can be very bad mnemonic. So I will talk about the mnemonic later. We have same slide subsequently. Next is outside in or inside out approach, and third one is conceptual approach. However, before getting into these approaches, let's see about the concepts first. We need to get to know about what these terms are. So the terms which I'll be dealing about in the subsequent slides is Hounsfield unit scale, windowing, some technical terms, and we'll be how to say having an interactive session on anatomy. Then all the lesions which we need to cover, which are blood or blood alternatives, mass and mass effects, edema, and stroke. So the most important topic which you'll be learning for today's stroke and its evolution. Fine. Any doubts so far? Great. So let me move on. Yeah. So first let's talk about Hounsfield unit scale. So in simplest terms, Hounsfield unit now it's just a number which says how much gray is the voxel. Voxel is that I told you 3D pixel which carries information, right? So one of the extreme would be complete black, one of the other extreme would be completely white. Let's say this one is 0, this one is 1. So between 0 to 1, the numbers contained in the voxel can be of any value, right? So corresponding to the value, we can get any shade of gray. So this is the illustration of Hounsfield unit scale. So we have, yeah. So we have some landmarks, landmarks which we need to look for it. First is here. By default, water's Hounsfield unit is 0. This is by default by definition. And air's Hounsfield unit is -1000. So these two data will be fixated in a computer, and correspondingly, these numbers will be generated for all these materials. Like white matter is coming on 2030, K matter is this range. And again, there's no need to memorize any of these numbers. It's completely all right. It's just you need to know these three numbers. These are more than enough. Air is -1000, water is 0, CSF is +15. And even if you have tendency to forget all these three, just remember this one thing: water is 0. That's it. Yeah. So you can see this whole strip, right? Here, usually the brain is made up of gray matter, white matter, and also this the cranial cavity uh, also has CSF, blood, etc. Unfortunately, all these materials have very similar density. So they all getting clumped up in this area, right? And if you have a good vision, it's really hard to distinguish between this shade and this shade. Just a millimeter apart, it by itself, we cannot even differentiate two shades of gray. So what we do is we do something called windowing. Windowing is nothing but we had a large strip, right? We are just shrinking all the strips. So it's basically we are indirectly increasing the distance, the how to say the gradient distance between each matter which we are dealing with. Yeah. So let me show you an example here. Yeah. This is the brain window, which is the default window. Let me show you here. Instead of having a complete strip of minus 1000 to plus 1000 strip, we have shrunk the strip between 0 to how to say 65, between minus 5 to 6 plus 65. So since we have shrunk up all these this whole gradient strip into this confined area, we can differentiate much better between white matter and gray matter. And if you want to see the blood also, this is coming as an outlier. So I would also like to talk about these two numbers which are given, width and level. Yeah. So width is just the length of the strip. So initially, which we saw here, right? So the width was 2000 here because the strip is starting from minus 1000 to plus 1000. So minus 1000 to 0 is 1000 units and 0 to 1000 is 1000 units. So overall 2000 units. Level tells about where the center of the strip is located. In this case, the center is located at 0. So the level of the image is 0. So why we need these two numbers? It's because we need to shrink this strip and we also need to move it across this gradient so as to fulfill our needs. So we have multiple windows. These are the top windows which are described in the literatures. First is brain window, followed by blood window, stroke window, bone window, and soft tissue windows. And if anyone had any doubt, you can again raise your hands. And you can say, please feel free to take screenshots and also take a lot of notes, please, because this is a highly dense topic and we need to cover a lot. Fine. Okay, let me move to the windows. So this is the default window, or I could say the most common window used. This is brain window. Brain window has an average width. Again, please do not remember this width and level. If you are using a lot of DICOM softwares, DICOM means digital information communication for medicine. So these are just compilation of lot of images. I told you earlier, CT is just a cross section of cross section of images, right, of the body, like a loaf of bread. So each bread is like an image. So all these image will be compressed and put in the file called DICOM file. So these DICOM files can be viewed in some of the softwares. So in these softwares also have a lot of options to change the windows and even scroll through it. So there's not much problem. Please, there's no need to remember these width and levels. You just have a basic idea in your head. And if you are taking notes, yes, you can take notes. And again, by practice, you will get used to it. Your mind would automatically know what to do. Now, in brain window, the width is 70, right? And the level is 30. From the level 30, I need to see. This is minus 5 to plus 65, right? So the level is 30. If I put the center here, so 30 minus 35, I need to go here. 30 minus 35 is here minus 5 and plus 35, 65. So I am getting a brain window here. Now, advantages, you can appreciate a lot of brain structures here, right? These are the various gyri and the sulci. So gyri are just the folds in the brain, and sulci are the depressions in the brain, right? And these are ventricles. Ventricles are just fluid-filled pouches in your brain. This is for the first years to understand better. And I will talk about these white things later on. And there are other things also, like this called tentorium cerebelli. So it's like a tent-like structure, etc. I'll be talking about that in our anatomy in a couple of slides. Now, here the disadvantage which we see here is, as you can see, the clotted bloods HU is somewhere around 80. But if I use this brain window, I'll be unable to differentiate between bone and blood or any other dense lesions. Lesion means any problem. So what should I do to differentiate the blood and bone, etc.? So I need to make another window where I could split this gradient to see the blood better. That's where I'm getting blood window. So the blood window is to appreciate small bleedings. There can be small bleedings which could accumulate here in these small depressions. or in subdural spaces. I'll be talking about that later on. So to appreciate those, we will be using something called blood window. Here you can see, if you're using blood window, see 80 level is at 80. So we can have a, how to say, a precise grade, a precise shade of gray for clotted blood, and any thin blood or any thin blood or CSF will go towards zero. On either dense structures would go towards the whiter areas, right? Now, the another thing is stroke window. So why do we have stroke window? The thing is, stroke has in the concepts slide, I told you that the topic could be stroke plus evolution, right? Yeah. So it's because stroke is not just a how to say, instantaneous event and you just end it up. Stroke progresses from the initiation of the bleeding in the brain to completely to the resolving of the how to say of the problem in your brain. So it might span from minutes to months or even years. So for every how to say time duration, like for every some hours or weeks or months period, we would appreciate a lot of changes in the brain. In those, the most how to say the one of the immediate features which we could figure out is gray-white differentiation. Yeah. So we know that in our brain we have two matters called gray matter and white matter. Yeah. So gray matter are the outer structures and white matter are the inner dark areas. You can see here, right? If I zoom in much better, you can appreciate the demarcation between the gray and white. Here, you can observe very well that counterintuitively, we can see gray matter is much more white than the white matter. It's like vice versa, right? White is more gray and gray is more white. So why is it so? It's because gray matter is principally made up of cell bodies, neurons, right? Let me go here. So neuron. Yeah. Here in neuron, we can see this is cell body, this is axon, and these are dendrites. Sorry, these are axon terminals. Sorry for that. Sorry for the mistake. Now, these cell bodies, these are primarily made up of waters and other proteins, etc. However, in axon, we also have a lot of proteins and other molecules. However, they are surrounded by a dense layer of Schwann cells or oligodendrocytes, depending. In brain, we have oligodendrocytes because it is central nervous system. Schwann cells are seen in peripheral nervous systems, which is peripheral nerves. Yeah. So these Schwann cells, what they do is they cover the axon with a substance called myelin. Myelin is a very fatty substance. And if you know the basics of science, oil floats on water, right? So fat is less denser than water. So the white matter, which contains a lot of fat compared to gray matter, which has more fluid, it is less dense, and hence we are getting a more darker image. Did you get this, Funda? Did you get this point? Please put a thumbs up. Because this is usually a confusing part for many of the students. Yeah. Oh, I'm getting 4 on the screen. Yeah. Let's go to the next one. Mhm. Next is bone window. Bone window is primarily used to differentiate any fractures or growths in the skull, right? Skull, yeah, since bones can be made or can be broke. So these are the only two possibilities: fractures and growths. Growths could be like any bone metastasis tumors could be there, or there's something called diplo. Diplo is that our brain is sorry, our calvaria, our skull. The skull's the scientific name is calvaria. So the skull, if you see here carefully, it has two layers. So these layers are called tables: outer table and inner table. So these two tables are made up of cortical bone. Cortical bone is it's very thick form of how to say bone. They're in simplest terms. In between, we can see some darker area, right? So this area is called diplo. This diplo area consists of cancellous bones and also a lot of bone marrow stuff. So in fetus and also in adults, we produce a significant amount of blood and blood products in this diplo bone marrows. So hence we are getting a darker area here. So to appreciate any how to say growth within or across, or if there's any how to say fracture, we can appreciate much better in bone window. You can see here. This gradient is much more wider. Level is at 600 and width is much 2000. So we completely shifted to scald gradient and left this area because this area is mostly air and air is far too different from bone. Yeah. And finally, soft tissue window. Soft tissue window. Okay, what causes diplo? No, diplo is how to say it's a normal structure. It's anatomically normal. Yeah, it's like in our bones. I will show you. I'll show you. Protein maintenance. Yeah, yeah. So see, we are having these are two tables. This is presumably outer table because it's more convex. Outer table and inner table. So in between, we are having a lot of cancellous bone, which contains a lot of bone marrow. This area is called diplo. We can see it much better. Like every how to say long bones uh, has some amount of how to say cancellous bone. So these cancellous bone contains bone marrow and usually flat bones. Usually flat bones like sternum, skull, etc. has a lot of bone marrow, active bone marrow, which is the red bone marrow. Red bone marrow produces blood and blood products. I hope it got cleared, Miss. Oh, sorry, Mr. Divich. Sorry. Yeah. Okay, I have planned for break. Shall we have a break? You need to take a small break because we'll be having, how to say, a peak in concepts right now after this slide. So I would suggest you to take a 5 minutes break. Hello again. So Bhaskar has asked to continue. Shall we just put up a thumbs up if we could continue? And meanwhile, if there's any doubt lingering in your brain, just ask me out. In module one was much more interactive. There were same number of 20, 25 people and they asked a lot of questions. They opened up their mic. And again, you are feel free to open your mic also, right? Again, this is one of the golden rules. Always ask the experienced. I'm a UG student. Yeah, I don't have much of experience as a radiologist, but yeah, I put a lot of efforts to gather a lot of information in my head. And yes, to the best of my knowledge and with the power of internet, yes, I can solve your doubts. And also in post-event form also. And if you're feeling shy to just open your mic or etc., you can type it here. Still feeling shy? We have a post-event form at the end of this event. So you can fill up your doubts in that. So can you sum up a bit on the windows before we start? Yeah, sure. Yeah. So is this what you asked, Tanya? Yes, the concept. Yeah. So the basic idea of windowing is, so this is the Hounsfield unit scale, right? So this Hounsfield unit scale is like putting all the possible shades of gray between black and white, between the structures which we could visibly see, namely air and particle bone, with the reference as with reference of water as the zero as the reference point, with zero for water, putting as the reference point. So we have multiple shades of gray, multiple shade for multiple parts of brain, right? We have CSF, white, gray matter, blood, etc. in our brain. Also, we have dura matter, etc. So we need to differentiate all these structures. It's really hard to differentiate between two shades of gray within this locality, right? Do you all agree? So what we do is using the power of computer, we do something called windowing. So windowing is basically narrowing this whole gradient strip into a confined area so that we can increase the gap of the grays between the structures which you're seeing. Now, if you zoom in closer, the gap between this shade and this shade is very high, right? From this arrow to this arrow is much larger. So I can easily differentiate with a good pairs of eyes, right? So for that, we are using something called windowing. So this windowing has two numbers associated with it, which is called width and level. Width says about the length of the strip which you are concerning. Initially, the normal Hounsfield, the standard Hounsfield is minus 1000 to 1000. So this strip contains 2000 shades of gray or 2000 Hounsfield numbers. So we are arranging in the form. Level says about the center of the strip. So the level is 0 in this case. However, to differentiate various structures in the brain, so as to fulfill our diagnostics. Like if you want to know more about stroke or if you want to know more about bleeding, etc., you are going to access specific windows to appreciate these specific structures. If you want to see more, how to say, if you want to appreciate more of the, how to say, brain parenchyma structures, is there any change, or you want to have an overall view, then brain windows the default one. You can go for it. Followed by if you want to see more of the, how to say, small bleeding areas or small collection of blood, if you want to appreciate more, then you can use blood window. Since you can see the blood is going beyond 65 here in brain window, so it will be completely white and you can't differentiate between blood as well as bone and any other structures in between these. So in stroke, we need to do something called gray-white differentiation. In stroke, in initial stages, within a few hours of stroke, we notice something called loss of gray-white differentiation. So what happens is, I told you this clear demarcation between this white color and gray color of gray matter and white matter we'll be starting to lose. It will be much of grayish, single gray structure. So if you want to differentiate, you want to localize which area we are facing loss of gray-white differentiation. So we are using something called stroke window. Bone window is used to see for fractures or growth associated with bones. And finally, soft tissue window. Soft tissue window you won't use much in CT brain. However, if you are seeing in some pathologies like any orbital edema, orbital or say bleeding, or if there's any fracture in the base of skull, etc., and if there's how to say fracture secondary to any tumors, like let's say um, tumors in the Peter's part of sorry, tumors above and around Peter's part of temporal bone, or let's say acoustic neuroma for the example. So these are soft tissues. So appreciate better. We are using soft tissue window. And if there's any how to say trauma to the how to say eyeball, let's say. So we need to check where it is bleeding, where the blood is percolating, etc. So at that point, we'll be using blood window as well as soft tissue window to appreciate the surrounding soft tissues. That's it. Also, if there's any, how to say, hypertrophy or atrophy of muscles, we have, how to say, temporal muscles here, right? If we want to appreciate better the temporal muscles also, we can use it. Fine. I hope it cleared your doubts, Ms. Tanya. There might not be, yeah, most likely there might not be an option for doing windowings, but that's okay. Anyway, we'll be seeing only a single image. So we need to, how to say, have a lot of practices with the brain window itself, right? Because usually patients would, how to say, let's say they are taking from any, how to say, private scanning areas, scanning centers. So they usually come to the hospitals with CDs. So the CD has the DICOM file. This DICOM file will be will be opened up in our computer, or if you have any, how to say, PAC system in your hospital, you can access through it and you can check for the image. There's no worry if you don't have windowing option. It's totally fine. Let's move on. So we will be having a detailed session on anatomy first before getting into the interpretation of CT brain. This is because according to my module 1 statistics, there are a lot of first year students. And also, I observed a lot of first years in this group also for module 2. So I wanted to make a lot of emphasis on this anatomy, right? So let me move on with the website which I need to access. No. So let me repeat again. So from the skin till the periosteum. Periosteum means peri, outside, osteum, bone. So outside osteum, there's a thin covering. So this whole thing is called scalp. Followed by that, we have our skull. Skull has outer table, inner table, and between cancellous bone substance. Called this area is called diplo. Followed by that, we have meninges. Meninges are just covering for our brain for its own protection and to avoid any, how to say, shear strain for the brain. So we have three meningeal layer: dura mater, arachnoid mater, and pia mater. Yeah. So dura mater is very thick and strong. It's also called pachymeninges. Pachy means strong. So, so it's very tough, and also it holds for a lot of sinuses. This is called superior sagittal sinus. It's because we have three axes to talk about. If you can see the cube here in the human anatomy area, as I move it, see, we are passing axis across the middle line like this from front to back. So this is sagittal axis. So we can move towards it and you can see the structures in this software. And horizontal is which we call axial. So going up and down. So from up to down, this axis travels. And finally, we have something called coronal. Coronal travels from left to right or right to left in horizontal axis, horizontal direction. So we are getting something called front and back. We can split it into front and back. So going with the terminology, this is superior sagittal sinus because there are other sinuses. Since this is located above, this is superior in the sagittal plane. So in the front to back plane, so it is sagittal and sinus. Sinus is a large valvulus venous area where blood is pulled up in the venous system, right? Got it? Now, arachnoid matter, it comes directly below dura mater. So there's little, how to say, very little space. So it's also, I could say, a potential space. So it's called subdural space. You cannot primarily appreciate it unless there's any fluid or blood collection within the area. Even there's any minute collection, you won't be able to appreciate much. It's that here it's much exaggerated in this picture. Now, followed by arachnoid matter, we have subarachnoid space. This is where CSF is there. CSF is that clear fluid in which our brain is floating, right? Yeah. So this arachnoid matter is slightly other to pia matter. This pia matter is closely covers the brain tissue, right? So the CSF which you're talking about is technically in between arachnoid matter and pia matter, and there is no such thing called subpial space. Only subdural or subarachnoid. Got it? These are the only things which I told 10 minutes. Sorry for wasting it. My apologies. Voice is breaking. I hope my voice is clear, I guess. Is my voice is clear? Hello?
Yes, Heerak, we can hear you.
Okay, thank God. Fine. So moving on. After meninges, we are going to the brain proper. Brain, the matters which we'll be dealing with. Yeah. So since axial is most common, let me go with it also. I'm going to the topmost part. You can see this dotted line here, right? You can simultaneously see it so that you can see where we are going. So we'll get entering through the vertex, going straight down. Yeah. So here they have marked it as pre-central gyrus, post-central gyrus, right? Yeah. So this is something called central sulcus. I will tell you how to identify it. Yeah. So this is central sulcus here. So if we can see here, if we can appreciate here, uh, yeah. So this central sulcus has a curve here, and then you can see this curve, right? Here also you can appreciate a curve. Um, eraser. Where is it? Yeah, you can appreciate this curve. So this looks like omega. Actually, I made facilities for using graphics tablet, but I am facing a lot of how to say technical issues here and there. Problem with the driver, I guess. Leave it. So this looks like omega. Here also, if I go further down, yeah, if I go further down, you can appreciate here this similar one, right? Are you able to appreciate it? Please put a thumbs up. Yeah, Saloni has put a thumbs up. Yeah, Sania, you have raised your hand. Any doubt, or did you use it instead of thumbs up? Yeah, please unmute and ask your question. Needed. Yeah, so let me proceed then. Fine. No, no, okay. Hmm. So there's also another thing here. This is called omega sign or reverse omega sign, which you could say. Yeah. So this is just I would say a technique to find out where is the central sulcus. This central sulcus is important because it divides this gyre into precentral gyre. Gyre is just an emboss. That's it. Gyrus means an embossment. So precentral gyrus and postcentral gyrus. This is important because precentral gyrus takes about is dealing with lot of motor activities, and postcentral gyrus is responsible for all the sensory activities. It carries all the sensations, sorry, all the impulses for sensation, and precentral carries all the impulses for motor sensations, and it will be processed here, and it will be communicated with other cortical areas also. Fine. There's also another technique called. Okay, let me erase this. There's no need. There's also you can see here, right? You can appreciate this red color over here. This is looking like a T, right? Reverse T. So this is called reverse T sign. Reverse T. So reverse T is again another technique to find out the central circus.
खेल चोर समझ लिया था तुम लोगों ने ये सोच लिया था कि ये तो कोई नल्ला बेरोजगार ये इसको तो जैसे घुमाएंगे वैसे घूमता चला जाएगा
Mr. Babar. Yeah. So, so if you find out the reverse T, then you can easily here see you can see here the T here. So if you find the reverse T, the sulci which is just behind it would be our central circus. This is another landmark. Thank you. Okay. So this is reverse T sign. And third one is there's also something called mustache sign. You can see here, right? Wait a minute. Again, annotate. This is looking like a mustache, or at least for the people who named it, it looks like a mustache. So this is called mustache sign. This is another landmark. So the sulci which is in front of it will be the central sulcus. So why is there an emphasis on central sulcus? Again, I told you these are the gyrus differentiation. That's pretty much it. And also, it's a very deep sulcus if you note it carefully. So if there's any blood collection in the subarachnoid space also, you can see it very clearly. We should be dealing with it later. Annotation. Fine. Fine. Okay, moving on. Wait a minute, let me remove the annotations. Sorry for the delay here. So as we move down, see you can see the reverse T here, omega, reverse omega here. We are moving down to the deeper brain nuclei. So if we go here, somewhere down. So we are somewhere here. Yeah. Are you able to appreciate it? Are you able to compare between these two? Please put a thumbs up if you can. Oh, great. Now, the important structures, the basic structures which you just need to know is, wait a minute. The basic structure you need to know is, this is called thalamus, right? It's marked down here. This whole orange structure, this is called thalamus. And these structures, this global pallidus externum, glutamen, and globus pallidus internus is also there. These all structures is collectively called lenticular nucleus, lentiform nucleus. Lentiform nucleus means it looks like a lens. So it's called lentiform nucleus and thalamus. So between these two things, we are able to appreciate a groove, right? Not a groove per se, an area of white matter. Yeah. So like this. In both the sides. So I'm not a Picasso, so sorry for it. Yeah. So this area, this is called internal capsule. So what internal capsule does is, it takes all the fibers, the nerve fibers from the upper parts of brain, and it will transfer it to the lower parts of brain through corona radiata, something called corona radiata. Annotate here. Now, if I just show you how is it, suggested. Yeah. So see, from upper parts, lot of fibers would come. Okay, coronal is much better. Yeah. We can see here. All the nerve fibers from the upper parts, upper cortices, will go down and getting condensed here. So all these fibers would just funnel and condense here. This area is called internal capsule. All these fibers which will run through are called corona radiata. Corona means crown, radiata means radiating. So it's radiating crown. So again go down and go through the spinal cord, etc. Yeah, through the cerebral peduncles in between. So other anatomical structures to discuss. This is the, how to say, basic brain nuclei which you need to see. Okay, another nuclear structure which you need to see is, which you need to appreciate, is something called basal ganglia or basal nuclei. That's the right term. But basal ganglia is an old term, and there are a lot of textbooks which are using that term. It's technically basal nuclei. No. Yeah, substantia nigra. Excuse me. So we can appreciate substantia nigra, right? So this whole thing is basal nuclei. Substantia nigra is one of the part of basal nuclei, right? Yeah. So which you can appreciate here as we go much deeper. This is glutamen, caudate nucleus. Caudate nucleus, I will show you here. It's much appreciable in sagittal view. Yeah. So this is caudate nucleus. So while you are reading neuroanatomy, you will get a lot of insights. For the class per se, the most important deeper brain nuclei structure are thalamus, lentiform nuclei, basal nuclei, and caudate nucleus, right? And followed by that, we have something called ventricular systems. So ventricular system, I can put up an image here. You can see here. Ventricular system, nothing but how to say, pouch-like structures which produce and which produce cerebrospinal fluid and transfer it to the CSF space around the brain, right? So this is how it looks. It looks stylish, and yes, it is stylish because there are other conditions where it'll be using these as landmarks. So this is called not this. Yeah, body of the lateral ventricle. So this is lateral ventricle, as you can see here. After lateral ventricles, these two lateral ventricles will, I would say, communicate with third ventricles through foramen of Monro. Yeah, there's something called foramen of Monro. So it will communicate with third ventricle. Third ventricle is there's only one ventricle. It's not a pair of ventricles. Again, it will connect via the aqueduct of Sylvius. Aqueduct of Sylvius to the fourth ventricle. Fourth ventricle is this diamond shaped structure. You can appreciate it. I will show you here in sagittal. Can yeah, this is the third ventricle. You can see as you go down. This is the fourth ventricle. It communicates through aqueduct of Sylvius or cerebral aqueduct to say. This fourth ventricle has three openings. You can see here, right? So lateral, these lateral two are called foramen of Luschka. And the central part is it's in mid. So M, foramen of Magendie. Two Luschka foramina and one Magendie foramen. Got it? Again, not to clump your brains much. You will learn it quite slowly in your anatomy also. I just since I'm just giving you an overview idea. Got it?
हाँ ससुर जी, यहाँ से बारात लेके निकलूं क्या फटाफट से? हाँ हाँ, अच्छा बारात से 1 किलोमीटर पहले.
Okay. Yeah, fine. So next is basal cisterns. Basal cisterns, yeah, that's a beautiful image here. So basal cisterns are just spaces where the CSFs are accumulating, right? So cistern, you can imagine like big areas, okay, big cavity, not cavitations per se, big places, big spaces, yeah, big spaces where you can appreciate a large amount of CSF getting collected. So let me show you the basal cisterns, and I will tell you how to identify it in the CT also. Yeah, ventricles, these are all the dark structures. CSF is, how to say, less dense, right? So these are the ventricles. Lateral ventricles opens into third ventricle. If you go further down, there's something called fourth ventricle. It's here. See, this is fourth ventricle. Got it? You can put a thumbs up. Okay, thank you, Saloni and Tanya. Now, see, if you can see this image, there are a lot of areas where there is, how to say, markedly high CSF areas, how to say, presence. So these are called cisterns. So this is called near foramen. It's called cisterna magna. We can even collect CSF here also. In adults, you can try. For any cases, we can try it here also. This is called pre-pontine cistern. It's in pontine, yeah. It's also right. Pre-pontine, because this is pons. In front of it is pre-pontine cistern. Here we are having cerebral peduncles. You can see in coronal area here. Mesencephalon, yeah. So we are starting with the midbrain here. So this mesencephalon. So since I told you, right, through internal capsule it will converge through cerebral peduncles. So in between these peduncles, there's space. This is called interpeduncular cistern. Next, this is suprachiasmatic cistern. You can appreciate it because this is stellar turcica, and we have optic chiasma here. Optic chiasma is just two optic nerves would join to a single part. You learn again in neuroanatomy. So yeah, it's so this is called optic chiasma. So above this there's a space. This is called suprachiasmatic, or we can also say supracellular system. Fine. Next is here superior system. It's much not much of yeah. Yeah. Mm, please wait. I'm having some issues here. Yeah. Am I audible? Yeah. Fine. Let me continue. So this is called quadrigeminal system. You can see these two embossments, right? I can show you here. Here we have pineal gland and we have four embossments, right? These four circular things. This in total is called corpora quadrigemina. So just above the corpora quadrigemina, we have something called quadrigeminal system, right? And connecting all these interpeduncular system and quadrigeminal system, if you see here, this interpeduncular system would come here. If you go around these two areas, just below these are called ambient systems. So let me repeat all this cistern names. You can just keep it in mind. Cisterna magna, prepontine cistern, interpeduncular cistern, ambient cistern, like a ring around it, quadrigeminal cistern, and finally supracellular cistern. Okay, got it? So all these cisterns have very important role when taking notes about subarachnoid hemorrhages. Fine. And last one is vascular system. We'll be talking about the blood vessels. Blood vessels, there's not much to see about much. We need to just appreciate circle of Willis and the areas where there is arterial supply by each artery. Fine. Those are the two things you need to see. Circle of Willis. Yeah, I need to show you the cisterns, right? Yeah. Here, if you go much down, we have the star-shaped area, right? 1, 2, 3, 4, 5. 5 points would be there. Star-shaped. This is called supracellular system. I'll tell you the importance. If we go, is there any lag? Hello? Are, are you seeing any audio visual lag? Okay. I'm not. Okay. My internet speed is kind of good here. You can't see the screen now. Isn't the screen visible? It is visible, I guess. And because yeah, it is visible. So let me do it quite slowly. You can see. Okay. I forgot to do this most important thing. Okay, let me share you this one, the link for it, so that you can do it real time. Fine. My sincere apologies for making this delay. I almost forgot that I need to send you this link. Yeah, you can use that right now also. You can use it real time to get to know about it. So you can see this image, see this video. This area is called supracellular system. This is the midbrain with cerebral peduncles. It will start here, right? So this looks like a Mickey Mouse, right? This is called the Mickey Mouse appearance of the midbrain. This just to how to say locate where is midbrain or something. Fine. Yeah. This area is called, yeah. This is called quadrigeminal system. This is corpora quadrigemina. Colliculus is just one of the balls. Superior inferior colliculus will be there. This is quadrigeminal system. And connecting all these two would be ambient system. If you go much down, we have fourth ventricle here. Fourth ventricle is just below and posterior to it. Yeah, this is pre-pontine system. We have came to the pons because it's starting to get more round. And to find out pons, which area is pons, you need to see this one, this round thing. This is basilar artery. In circle of Willis, you can see this straight big artery, right? This is called basilar artery. So this is the basilar artery. So this is pons. So in front of this pre-pontine system. And finally, if you go more towards the spinal cord, you are getting large space around the spinal cord. This is called cisterna magna. This literally means biggest cistern, right? So what are these uses? The uses is primarily because one is blood collection. We need to identify it. Next is brain is a very soft and squishy structure, confined in a very hard cavity. So there's a chance that it might herniate into various areas. So these herniations can be much appreciated. If these systems cannot be if these systems disappear, this is called cistern effacement. Effacement means it's just disappearing. I'll talk about the terms later on. Vascular system, I just need to show you two images. Arterial supply of brain. There was this image, I downloaded it, but I did not incorporate in the PPT. Vascular techniques, yeah. It's here also. I'll show you. Okay, there was a blood supply marker also. Landmark stats. Okay, fine. I'll show you here itself. Yeah, these are the important things you need to see here. So the main things you need to consider it, anterocerebral artery is this area, middle cerebral artery is this area, and posterior cerebral artery is major in the posterior area. The major supply to the brain is given by middle cerebral artery. You need to keep it in mind. This is the most, this is the important point when it comes to vascular system, getting to know about basics of vascular system for basic interpretation of CT brain. Got it? And this is a circle of Willis. These are the arteries corresponding to it. Anterior cerebral artery, middle cerebral artery, and posterior cerebral arteries are coming with this. Basilar artery I showed you in front of pons, and vertebral artery would come near the spine. See, you can see these two dots are here, right? These two dots are vertebral arteries. To figure out where would be anterior artery, etc., you need to see. For anterior cerebral artery, it will come here. This is lateral ventricle, right? Lateral ventricle, in front of lateral ventricle, we have cingulate gyroside. Just here, we have the first segment. It is called A1 segment. There's no need to read A1, A2 and all. Those are radiology terms. So, or surgical terms, to be said. So, anterior cerebral artery usually comes here. If there's any, how to say, thrombosis. Thrombosis means blood clot. So, there will be a loss of blood supply to this area. So, the area which you appreciated here, this yellow area, all will show changes. I will show you what will be the possible changes. Next is middle cerebral artery, all these whole areas. You can find out middle cerebral artery here. This is called Sylvian fissure. Okay, or yeah, lateral sulcus. You can see this one, right? So this is where the temporal, I can show you. So this gap is there, right? This is called Sylvian fissure. So it runs within the Sylvian fissure. So the part of middle cerebral artery. This is I told supracellular system, right? It goes in like star shape, 1, 2, 3, 4, 5. So the first part of middle cerebral artery goes through one of these arms of the star. Then you can appreciate the second part within the Sylvian fissure. You cannot normally appreciate the blood vessels clearly because again I told you, brain window is the normal windows, not much how to say appreciate the differences between blood, CSF, and other soft tissues. Got it? My mouth is getting dried up. Please wait. All right. So any doubts in this? I'm closing the anatomy section. Any doubts in this? Please put a thumbs up if you are okay to continue, or please raise your hands. Okay. And if by any chance you feel it, how to say, fast or slow by any means, you can always have the YouTube recordings available in our Rotary Club of Medicare YouTube channel. Fine. Please respond. Yeah, we have reached the 2 hours mark. Fine. It's not having here. Shall we proceed? Can you even open your mic and say yes? I'm feeling lonely here.
Yes, sir.
Okay, thank you very much. Who was it? Saloni. Okay. Yes. So moving on to the anatomy, then these are the technical terms we need to know before getting into the topics per se. So the technical terms are hypodense or hypoattenuation, hyperdense or hyperattenuation, which is just as how to say a posh way of saying it is more black or it is more white. That's it. And isodense is similar density. So if two areas of the same tissue are isodense, means most likely they are having similar characteristics. Fine. Or you can say this also synonymously used for areas to say it as normal. Next is effacement. I told you there's something called ventricular effacement, cistern effacement while teaching the anatomy, right? So effacement is disappearing. So when would a pouch or some space would disappear? When it is occupied by something else. So effacement usually says there's some, how to say, pressure from outside the space in towards it, towards the center of it. Next, these two terms, extraaxial and intraaxial. Extraaxial means around brain tissue and intraaxial means within brain tissue. These are the simplest way to define these technical terms. Because we will be using these terms more often. We in the sense, most likely you, because I wanted to be interactive session, I'll be showing you a lot of pictures which you would be commenting upon, right? Fine. And if there are any other technical terms, I shall tell you down the lane. Fine. Let's go with the specifications which we need to learn. First is blood. First, we'll know whether it is blood or it is not. That's the first question we need to address it. The subtopics we addressed here, the blood, mass effects, etc. It's how based on we'll be approaching our CT brain interpretation, right? So there's a reason for arranging that subtopics in that order. Good. Now brain, blood, the acute blood clot. The Hounsfield unit is somewhere around 80. You can see here, right? So if there is any hyperacute or active bleeding, so there's a gushing of bleeding, active gushing of bleeding going on in the brain, it will be darker than this blood clot. And if there's any chronic, so if the blood was been for how to say weeks or so, then its HU will reduce very close to CSF. Here it's zeros given for CSF, which is wrong. Water is 0. Okay. So you can see the peak here. There's one point where the clotting of blood will be complete. There will be a peak of Hounsfield unit. Before and after that, there will be regression of it. So this is the funda you need to keep in your head. So this is the quote I made here or something. All glitters are not blood. It's because the differentials of blood here are, the common differentials are calcification, 1 point. Second is wrong windowing, our own fault. Third one is fibrosis. You can put this wrong windowing in the third one because according to the last golden rule, you must believe in yourself. If you're unable to find any, then you must suspect over yourself. Fine. Examples for these are the bleeding. I will like to show you. Hyperacute plus acute, both are here. You can see here. Let me zoom it in. Sorry for that. So I'll be talking about what are types of hemorrhages in the subsequent slides. We can for now we'll say about the bleeding. That's it. There is blood here. How is the blood? Because it's denser than uh, brain tissue and lighter than bone. So most likely this could be blood. So you can see white areas, but also you can see black areas, also black roundish areas. Are you able to appreciate it? Please put a thumbs up if you can. Yeah. So these white areas are where there is acute blood clot. It has happened. These black areas, which in within these white areas, are where there is active gushing of blood. There's not enough time for the blood to clot. So this thing is this phenomenon is called swirl sign. Swirl because this looks like a whirlpool, right? So this is called a swirl sign. So you can see acute blood clot with hyperacute. So hyperacute blood gush. Here you can see chronic blood clot. Since blood after getting clot, it goes for thrombolysis. Thrombolysis is breaking of the this blood clot. So what happens is there is reduction of valency of these iron molecules. There is increase in valency. Yeah, there is increase of valency from 2 plus to 3 plus. So what happens is we will lose a lot of iron molecules. So the density also reduces. So it will go towards the density of CSF. So it's dark here. So this is chronic blood clot. Here, this is a special case here. This is acute and chronic. Can you identify which is acute and which is chronic? You can put it in the chat box or open your mic and speak it up. You can see the fluid demarcation here. Can you say which is acute and which is chronic based on the previous slide? Posterior acute and anterior chronic. Well done. Well done, Nikita. You're doing really great. So this posterior part is acute and this is chronic. Fine. I hope this concept got stuck to you. If you have any doubt, please ping me in the chat box. Moving on, the differentials for blood are calcifications. First thing is calcifications. Calcifications can be of physiological or pathological. This is the broad classification. You need to know the physiological calcifications especially because, okay, there's a U here. You can remove it. It is choroid, not choro. U is not there. That's the point. So physiological calcifications are important to identify because you might confuse a lot with the blood gush or blood clots. Yeah. So physiological calcifications can happen in many places. The most common areas in the descending order of commonality is pineal gland, followed by choroid plexus, followed by habenula and basal ganglia or basal nucleus. And pathological, these are the conditions. You can take a screenshot of this. This is too much of a flowchart. Moving on. This is the image of some example images of physiological classification. This is pineal gland. Okay. So you know pineal gland, right? So the other name for pineal gland, third eye, right? So you saw that corpora quadrigemina. Just above it, there was some small projection. If you would have noticed properly. Sorry that I didn't say it. So it is called pineal gland. So pineal gland is responsible for our sleep-wake cycle. So this is the most common entity to get calcified quickly. And this is pineal gland. Along with it, in front of pineal gland, there is something called habenula. Habenula is just a connection. That's it. You can just remove it like this. That's more than enough. Here, you can see this image, pineal gland calcification. Oh, there's a lag, audio-visual lag here. So this is pineal gland calcification, and these two things. These are choroid plexus. I told you that these ventricles are producing CSF, right? So how are they producing it? So there is something called choroid plexus. What they do is the blood would pass through this choroid, would pass through some the filtration slits, and this process is called ultrafiltration. This ultrafiltration would cause most of the fluids, most of plasma to enter into the ventricular cavity, which we call it as cerebrospinal fluid. So these choroid plexus are also very common in getting calcified. This here is called Fox cerebri calcification. Fox means sickle, which we used to cut, right? Or farmers use a lot, right? So this part, you can see a sharp line, right? Which would go above the brain. Let me show you here, Fox cerebri image. I told you within which the superior sagittal sinus is there. So this Fox cerebri can also undergo calcification or fatty changes. It depends on whether the age. The more elderly you are, the most likely these common areas, the physiological areas would get calcified. This is the Fox cerebri. Got it? Okay. Yeah. And finally, this is basal ganglia. I showed you that area, right? Substance nigra and other area. This is basal ganglia. This can also undergo calcifications. So these are some of the physiological calcifications. Moving on for pathological calcifications, there are a lot of reasons going on. These are subcortical calcifications because this is cortex just below it, subcortical calcifications. These are multiple calcifications. This could be because of any tumor, but as you can see clearly, this is non-contrast CT. You cannot appreciate much of the lesions, any circle or irregular structures, anything. The only big thing is this one, just because of calcifications and other changes, and other blood changes. So since we cannot appreciate much, we need to do something called contrast enhancement. Then only we can comment upon whether this be a tumor or any other things. But here you can clearly appreciate if you are using bone window, etc. These are clearly calcifications. And also before concluding, we need to know the history of this patient. Got it? Fine. These are also multiple calcifications, intracranial calcifications. Sorry, intracerebral calcifications. Yeah, both are similar. Okay. Got the point? Any doubts so far? Sorry to interrupt. Can we take a short break after this? Yeah, I have planned for a break after 4 slides, I guess. Okay, we can take a short break now. Fine. Shall we take a short break? Please put a thumbs up. Okay, thank you very much. So, I don't know, 4 slides, it might look like it, but it's much large. I have made only 4 slides, but it's those are large concepts. There are many slides which I removed in this process because there are a lot of issues with the DICOM files which I had. So yeah, there's nothing much of loss here. The concepts, everything are confined here. The example data are not available with me in the subsequent slides. That's it. Nothing much. Please continue for how long? Yeah, I think it might go for much more long, Mr. Tahiri. Want to continue? Please continue, please. Fast. Okay, fine. May I take just another more concept? it will end quick, I guess. Just another topic, intracranial hemorrhages. Because since we are dealing with blood, just continuing with the ICH should be better, I guess. Yeah. uh, Fine. So, hmm. So intracranial hemorrhages, which basically means there's some bleeding, active bleeding going on within your head. So there are various types. The types are extradural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, and intracerebral hemorrhage. These intracerebral hemorrhage can be further divided into intraparenchymal and intraventricular. Extradural means I told you dura mater, right? So just above dura mater, but within the skull cavity. So what happens means our skull have sutures, right? You must know. Our brain have a lot of lines, so-called sutures, where the periosteum will, how to say, will attach, will be firmly adherent. So it will be like a margin. You can the blood if the blood is between uh, the dura mater and the bone, so it will be collecting very near to the periosteum, right? So what happens means blood, that space would start swelling. However, it will not go beyond the margins of the sutures. Yeah. So these are the short tricks which you need to remember it. Extradural is lemon shaped because here there will be something called sagittal suture. Sagittal suture. Here there will be something called lambdoid suture. So between these sutures, these blood cannot go further out because they are so tightly adherent to the bone. So blood will be confined here. So there will be convexity towards the brain. This is called epidural or extradural hemorrhage. Next is subdural. Subdural is between dura mater and arachnoid mater. I told you, I emphasized you that subdural space is a potential space. So what happens if there's any blood collection? It starts making a convex area because blood is because the brain is softer, so blood starts collecting. The convexity will still be maintained. However, if there's any more bleeding, but if there's more bleeding, there's a chance that this convexity, the inner convexity, might get lost, might become straight or become more convex. Now it is concave here. Third one is subarachnoid hemorrhage. Subarachnoid hemorrhage is classically described as star-shaped because I told you suprasellar cistern is star-shaped. So in cerebrospinal fluid is there in suprasellar cistern. So usually in subarachnoid space, the blood will get mixed with this CSF. So it will show much say hyperdense area in the suprasellar cistern, which should be star-shaped. Fine. Next one is intracerebral. Except all these area wherever there is uh, bleeding, it is called intracerebral. Since brain tissue is also produces a lot of pressure, since it's thicker than blood CSF or any water things, so it also puts a pressure. So there is very little spread. It will be more like localized parts. This has two parts: intraparenchymal, which is within the brain tissue, and intraventricular. Ventricles, I told, those are pouches producing CSF. So if there's in blood collection within the pouches, those are called intraventricular hemorrhage. I will show you the image here. Again, as because of DICOM files are missing, I used Radiopedia as an alternative. So yeah, so as we move down here, if we can see any gross changes, these are the gross changes. I hope you can appreciate. Can you see my cursor moving? Please put a thumbs up if you can appreciate it. Yeah. So here we can appreciate a lot of bleeding. Why bleeding? Because again, I told you this density, it is hyper dense than the brain tissue, but hypodense than the bone. So here, As you can see, there is convexity and it is spreading a lot. So most likely this could be a subdural hemorrhage. And you can see here, wait a minute. Now, if you look carefully, there's some lens shape, some lemon shape, right? It is classically described as lemon shape because if it goes too much. Otherwise, you can say it as lemon shaped, right? The convexity is towards the center of the brain tissue. So this is most likely epidural hemorrhage. Now, if we go much below, see, this is a suprasellar cistern. You can see these are the CSF spaces. In CSF spaces, we are able to appreciate blood. And also, if you're going above, I'm unable to appreciate any. Sulci are also gaps, right? So these gaps contain CSF. They can also contain blood if it's a subarachnoid hemorrhage. However, there is minimal subarachnoid hemorrhage here. As you can see, only one hand of the star, subarachnoid hemorrhage, sorry, of the suprasellar cistern is having some hyperdense lesion. This could most likely be blood. So this is a subarachnoid hemorrhage. So this is a case where there is subdural hemorrhage, subarachnoid hemorrhage, and extradural hemorrhage. All three in a single case. Fine, got it? Shall we take a break? Yeah, fine. Yeah, let's take a break. 5 minutes. Shall we? Hello again. Let's continue, shall we? Please put a
Yes,
thumbs up.
sir.
Okay, fine. Thank you. Let me share it. Okay, we'll be wrapping this up in about 30 minutes or so. Yeah, CT brain is much more larger than my slides. However, I wanted to give you a foundation and a strong basement regarding the CT brain. That's right. To be more precise, this is CT head. However, I reduced all the base of skull and other nose and other structures. So I confined it to CT brain. And CT brain in itself is very vast and has a lot of other stuff also. Okay, let me continue. Shall I? Next is mass and mass effects. Let me share my screen with you. Now, mass and mass effects. So I told you the two terms, right? Extraaxial and intraaxial. So just keep it in mind. Yeah. Extraaxial means which is outside the brain tissue, which is not in, which is around the brain tissue. And intraaxial is within the brain tissue. So this is the concept you need to just hold it up. And there's another term called midline shift and others called hydrocephalus and brain herniations. Let me talk about it using this. Yeah, this is a beautiful image I wanted to show you. As you can see here, yeah, if you can see carefully, there's some dark area, right? But it's really hard to appreciate it. So to appreciate better, we are giving something called contrast dye. It's usually iodine based. Iodine based contrast dye will be used here for CT. After giving contrast, I'm getting this image. So which is a roundish ball-like mass, a circular hyperdense mass in the frontal area, frontotemporal region. This is frontal, temporal. Temporal means towards the ear, temporal region. So you got it right. So in this, you can appreciate how it's much darker after we use contrast. So can anyone say whether it is extraaxial or intraaxial? Just by just using your imagination of the term which I used in the last slide. How does it look like? Does it coming from around the brain tissue, or it's or is it sprouting from within the brain tissue? Okay, so actually this is extraaxial. Because as you scroll through the CT here, just a single image is enough. However, as you scroll through this, you will always find how to say no discontinuity between this bone and this lesion here. Also, that's also the characteristic finding of something called dural tail. Can you see here? So let me annotate here. The green is not a good color. So instead of could you please wait for 2 minutes? Yeah. If you see carefully, let me annotate here. Yeah. So instead of going like this, taking a sharp turn, it's having this curve turn, right? Can you appreciate it? This ball is coming like this, and it's just going there and attaching it. This is called dural tail. Dural tail happens when there's something that's coming outside from the dura. So the dura is getting lifted. That's why you're having dural tail. Got it? Got the concept? Are able to imagine it? Yeah. So this dural tail is seen here. So this is a classic case of meningioma. Meningioma means you can get the term right. Meninges, oma, a tumor, tumor in the meninges. So what is it doing is it is lifting the dura. So we are getting a dural tail along with it. Got it? Manipulations. And I would also like to use, let's say, other images too. Midline intraxial mass. Intraxial mass, yeah. Just by seeing it directly, you can just say it's an intraxial mass. No need to know the perfect diagnosis. Yeah, that is not the main objective of any of the modules which we will be discussing in our event. So our main goal is to just appreciate the how to say findings and report it. That's it. Diagnosis part, we can have a probable diagnosis in our mind. That's it. We can see some suspicion here. So to rule out the suspicion, I am giving contrast. See, so there's something growing up. So what is this? Is it intraaxial or extraaxial? Anyone? Intra, how so? Yeah, how so? Any reason in your mind? Okay. So there was a catch here. This is actually extraaxial mass. Yeah, you might feel surprised. It's because you can see here there is still connection between this fox cerebrae. Fox cerebrae is derived from dura. Again, It's intraaxial means it should come from within the tissue. So there is space here. It's coming from fox cerebri and not from the brain tissue. If you appreciate it carefully. Let me share you the link so that you can also appreciate it. You can open it up and check for yourself. Scroll through it and you will get to know that it's it's no way coming from brain tissue. It's affecting it. It's putting pressure on something. It's affecting it. However, it's not coming from the brain tissue per se. If you can appreciate properly. See, this one also, it's coming from here. So this is also a case of meningioma. However, if I see this one, this latest one, here you can see, this is an intraaxial mass because it is clearly coming from the cerebellum. Oh, wait a minute. This is from cerebellum. Hmm. Contrast. Yeah, can you say now it is, are you able to appreciate whether it's intraaxial or extraaxial? Please pull up your hands if you are unable to appreciate it. Oh, good. You are able to appreciate it. Yeah. So this is an intraaxial mass in the cerebellum. So this is the right cerebellum. While doing the systematic approach, which will be in quite a few minutes, I'll tell about how to read left, right, etc. Fine. And we have midline shift, hydrocephalus, and brain herniations. Midline shift, I will tell you in brain herniations part. Hydrocephalus is basically just, I'll show you just the image. I wanted to be more interactive, but this is much more laggy in my computer. Yeah, I'll just show you from here itself. There's no need to scroll much because it's pretty evident. This is a coronal section, coronal CT. So you can see ventricles must actually be only this much, but it's much enlarged. There could be reasons for it, but here one of the reasons, but here the diagnosis is hydrocephalus. To be much more better hydrocephalus, I'll show you here. Yeah, see, we saw in earlier images that the lateral ventricular was very thin. Here it was very much large when compared to the normal things. So this is hydrocephalus. Hydrocephalus means more fluid in the head, literally. There are various types, communicating, non-communicating, etc. But those are theory. Then brain herniations. Brain herniations. Before telling of brain herniation, there's something called Monroe-Kelly doctrine. So Monroe-Kelly doctrine states that our brain, our cavity, our skull cavity is a confined, how to say, solid block. Can we appreciate cystic changes in meningioma and CT? Cystic changes. Yeah, you can appreciate cystic changes. And again, not every swelling is meningioma. I don't think meningioma has cystic changes in it. But yeah, you can appreciate cyst in general CT. Because anyway, cyst would have fluid in it. Fluid would be much less denser than the brain parenchyma. Then yes, you can. Fine. Here, Montefiore doctrine states that we have a solid how to say confinement of skull cavity. This skull cavity has confines brain tissue, CSF, and blood. So, if there's an increase in one of the component, another component must be compensated. So, if for example, if there is more blood, so there must be compromise in the CSF volume or brain tissue volume. If there's more in CSF volume is increased, means there must be compromise in the blood and brain tissue, and vice versa, and so on. So these are the types of brain herniations which you need to look for. The most common is subfalcine herniation. This is Fox cerebri, I told, right? So below it, subfalcine herniation. If there's a more pressure here, the brain tissue is more pliable, so it will move towards the side. So how to identify subfalcine? It's very easy. Lateral ventricles, we saw it as symmetrical, right? If it becomes asymmetrical, like if you are able to see two lateral ventricles on the same side, then you can say it's subfalcine. I'm just rushing things up. I'm not able to show a lot of images right now. So yeah. Next is uncle herniation. Uncle herniation is also very common. Please wait. There's something here. Yeah. So this uncle herniation is also called lateral transtentorial herniation. This is tentorium cerebelli. It looks like a tent. I'll show you in this image. Where is it? Yeah, you can appreciate here also. Are you able to appreciate some wine glass kind of thing? Put a thumbs up if you're able to appreciate it. This one, this white line. Watch my mouse carefully. This is stalk of the wine glass. Yeah. So this is part of the tentorium cerebelli. This is also again something like a Fox cerebri, again derivative of dura mater. Yeah. So if it goes across this tentorium, then it's called transtentorial herniation, which has all different types. And this is tonsillar herniation. Cerebellum has a lot of parts. These are hemispheres. There's something called vermis, something called tonsil. Cerebellar tonsil, if it goes down, then it's called tonsillar herniation. So I'll just tell you the points how to identify it. You can just take a note of it. I can even type it if possible quickly. Yeah. So for subfalcine, look for subfalcine. You need to check for lateral ventricles on both sides. Sorry, lateral ventricles on same side. Both lateral ventricles on same side. If you're able to appreciate a slight of it, then it is subfalcine. Right? If you are able to appreciate effacement of this one, effacement of quadrigeminal cistern and ambient cistern, etc., then there could be a transtentorial herniation. So effacement means again disappearing. Effacement of ambient, interpeduncular, and quadrigeminal cisterns. Usually tells about uncle herniation. And tonsillar herniation. For tonsillar herniation, this is for transtentorial herniation. Okay. This is called, okay, there are various types of brain herniation. Herniation, first one is subfalcine, most common. This is Fox cerebri. This is brain tissues going below the Fox due to pressure from here. It's slipping towards the side. So this is subfalcine herniation to the right side. This is uncle herniation. This is called uncus. This is a part of temporal lobe. This uncus, if it moves down, if it crosses the tentorium cerebelli, this wine glass area looks like this. This is one of the dura mater derivative, similar to Fox cerebri. This is called tentorium cerebri. If it crosses it, it's called transtentorial. There are various types. The most common is uncle or lateral transtentorial. Final one is tonsillar herniation. Again, tonsillar herniation, there's something called tonsil of cerebellum. It's again a part of cerebellum. It might slip downwards. If the pressure is increasing here, it might slip and move downwards towards the spinal cord towards the foramen magnum. This is foramen magnum. The base of skull, we have a large hole. So this is called tonsillar herniation. To find it out, I'm typing out all the things in the chat box. For subfalcine, you need to check if this both lateral ventricles are slipping to the same side. And you saw, you saw a lot of cisterns, right? Ambient cistern, quadrigen cistern, etc. In and around midbrain. If it is lost, if you're unable to appreciate, then there's a chance that there could be a transtentorial herniation. And if you're unable to appreciate foramen magnum or cisterna magna, yeah, if you're unable to appreciate cisterna magna, then most likely there could be a tonsillar herniation. Cisterna magna, effacement, is tonsillar. Did you understand now, Saloni?
Yes, sir.
Did you? Okay, thank you very much. Okay, I'm losing a lot of things here. There are a lot of things to cover too, but yeah, you can take a screenshot of this one. Okay, we don't have time to discuss about Karnahan notch and durate hemorrhage. Those are some special things you can observe during herniations. Wonderful doctrine again. This is edema. Yeah. So the point to take note is vasogenic and cytotoxic. There are two kinds of edema. Edema is just fluid accumulation in the interstitial space outside the cell. Two types: vasogenic, cytotoxic. Vasogenic is where how to say? I will tell you the vasogenic. There's something called blood-brain barrier breach. Wait a minute. Yeah, in vasogenic, there's something called blood-brain barrier breach. You know, there's how to say? Brain is a very how to say important organ. So to prevent toxins entering from our blood into the brain tissues, there's something called blood-brain barrier. So if that breaks due to any infection or tumor, etc., there's a possibility that we could have vasogenic edema. Vasogenic edema is classically appreciated as accentuation of gray-white differentiation. So you can see this is gray matter, this is white matter, right? You can appreciate some how to say clean demarcation. However, this demarcation would become more better in case of vasogenic edema. However, in case of cytotoxic edema, the blood-brain barrier is intact. There is problem with some sodium potassium pumps. So what happens? The overall fluid level in the brain tissue doesn't change. So what happens? There is loss of gray-white differentiation. So you can see here gray-white differentiation much better, right? Demarcation. Here you cannot appreciate much better. These are all the single shade of gray, right? Yeah, this is impact area. Ignore this. Around this, you cannot appreciate gray-white differentiation. Are you able to understand it? Please put a thumbs up. Okay, let me move on with no breaks. Yeah. So this is the most important things. I think I would be skipping the practice session, I guess. Okay. I should not. Fine. How much more time would you be able to sit? Would be able to have a seating? I need to know. My sincere apologies for taking for more than 3 hours. I planned it for 2.5, 3 hours, but I might get a bit too far. Anyway, if you get more tired, YouTube session will be there, but I need a company to teach. That's why. Your insights, please. Or may I break it into 2 sessions? Model 2 as 2.1 and 2.2. You can complete the whole. Yeah, how much time? Okay, fine. Without further ado, we can go. Stroke. So this is the most important topic which I wish to discuss in this event, in this session. So stroke, you basically know there is there is oxygen supply has been cut for the brain tissue. That's the basic way of saying stroke. So what could be the causes? Either there could be thrombus, a clot, which can how to say completely block the blood vessel, blood flow in the blood vessels, or there could be hemorrhagic stroke. Hemorrhagic means the blood vessel got ruptured. So either there could be blood vessel rupture or blood vessel obstruction, occlusion. So ischemic and hemorrhagic strokes respectively. So this is the evolution of stroke. You just need to know. This is initial stages. Initial stages, if we can appreciate it clearly, there's something called loss of gray-white differentiation. So here you can appreciate a few. This is anterior cerebral artery supply. Here you can differentiate gray matter and white matter. However, here, if you see, you cannot appreciate much. The gray-white differentiation is pretty much, lost here. On subsequent days, we can see blood has been there's been infarction. Infarction is usually dark in color. Okay, so I told you for blood, right? Blood, if it's very hyperacute or active, it will be dark, followed by hyperdense. It will become clot, and followed by again hypodense, the more chronicity. However, in brain tissue, it forms this linear pattern. It has a isodense. It will be isodense. The more the infarction, the more duration of the infarction, the more hypodense it becomes, more darker it becomes. Fine, just keep it in your mind. So as the time passes, it becomes much more darker, and it tries to go for resolution. Fine, good. Let me go to the next slide. So this is the evolution of stroke pattern. So this is day 0, 1, 2, 3, and weeks and months. You can remember like that. Within hours, you can appreciate the loss of gray-white differentiation. To appreciate it better, you need to use stroke window. Again, I'm saying it. Next, you can appreciate the areas getting a bit more darker. Okay, these are not corresponding images. These are separate images of their own. Here there is middle cerebral artery infarction. Here there's middle cerebral artery on the left side. This is the right side, this is left side. All are different images. This is just an image from Radiopedia. I just took it up. Fine. So the more as the days goes by, the duration of infarction is more, it becomes much more darker. Here there's something called craniotomy has been done. Decompression craniotomy. Since blood, since it is swelling due to edema, there might be pressure increase. Intracranial pressure will be increased. So to decrease the pressure, surgeons what to do? They will remove part of the skull bone here. So it is called decompression craniotomy. Fine, it has been done here. Okay, here there's something called. Okay, these two are the same image. Here there was the infarction, but as the days moved by, there was this loss. It became as if normal, right? There is infarction here, but it became as if it got normal. It got resolved. However, it is not the case. This phenomenon is called CT fogging phenomenon. CT fogging phenomenon, where after a few weeks, like 2 to 3 weeks, what happens was this infected area will try to look normal. However, to confirm this, to rule out this CT fogging, we need to have thorough history and as well as we need to do a CT angiography. We'll be putting contrast to the blood vessel, and we'll be checking how the blood vessel is arranged. This blood vessel will not be available here if you look carefully. So the blood vessels would go like this, would branch off to various parts. There won't be a blood vessel filling here. If you use the CT angiography here, again, there won't be blood vessel here. But in normal brain window, this looks absolutely normal. This is after months or years. Months or years, what happens? this brain tissue becomes liquefied and it becomes as dense as CSF. So it becomes isodense to CSF. So this is the evolution of stroke. So the key home point, the take home point here is first the immediate changes you need to look for this one, loss of gray white differentiation. Followed by that, you can appreciate the impacted areas. You need to localize which artery. If it's side means middle cerebral, if it's in the frontal area, anterocerebral. In the parieto-occipital areas, this is the parieto-occipital area. This is posterior cerebral artery. And again, a CT fogging phenomenon you need to keep in mind. Fine. Yeah, these are the ways you can figure out how to find out the strokes, how to find out the person had stroke. So these are the diagnostic points. The most certain point is hyperdense MCA, which means middle cerebral. If you are able to find the middle cerebral artery, you can appreciate the clot. Clot is hyperdense, right? So if we can directly see the clot in CT, then definitely there's a thrombus, then definitely there's an infarction. You can sure shot say it is a case of stroke. Again, the same thing is MCA dot sign. Both are same. Next is loss of insular ribbon. I told you gray white differentiation is lost, right? Yeah. So this is the Sylvian fissure. Just around it, you can appreciate how to say the insular ribbon. I will show you a normal picture of the insular ribbon. Yeah. Mm, yeah. Let me zoom it here. Okay, fine. Please wait. I'm taking a good picture of it. Yeah. So this is Sylvian fissure. Here you can see the gray white matter has been differentiated here. This is the gray from gray matter. This is the white matter, right? On both sides you can see. Let me take a clear picture also. We lost it. Mm, yeah, you can see the gray matter here, right? This is called insular ribbon. Are you able to appreciate it? Please put a thumbs up. Yeah. So this is insular ribbon. This insular ribbon is lost, which means that there is loss of gray white differentiation. That's it. That's the, I'd say, simplest way of explanation to that. Next is MCA loss in CT angiography, which I told you, right? In CT fogging, it might look normal, but in CT angiography, if you do it, you won't be able to appreciate the blood vessel in itself. Okay, finally we are up to application. So the two important steps are first step and last step. Step 0, before starting the CT, first we need to verify our patient. We need to get his patient demographic details, have a thorough history and examination. Because without that, we won't be able to pinpoint to a definite diagnosis. This is according to the golden rules. Last one is report to the senior. This should be our nth step. Fine. Hmm. Yeah. So let's have an exposure to how to deal with it. Now, how to analyze it. So this is the core thing. So even if you watch this also, even if you're feeling sleepy, this is the time you must wake up again. So, okay, I didn't change these terms. These are from previous slides. Sorry for that. So I'll be giving some case scenarios here. you need to just how to say, look and appreciate it, and just give me what all you need to type in the chat box, what all are you able to appreciate it. Fine. You need to use the technical terms: hyperdense, hypodense, circle or irregular structure. For first years, you can use that how to say, in front or left, right, etc. For others, use the term frontal, temporal, and parietal, occipital, etc. So systematic approach. I told you there are three. I came with it. We are going to use conceptual method, which should be a kind of mixture of the first two ones. Fine. So this is again a trick I usually put in my mind to learn about the diseases which I'm reading for radiology. So divide into four: common physiological, uncommon physiological, common pathological, and uncommon pathological. Fine. So let me share you this link. You must open it. Actually, this is the interactive part of the session. Open it. Now it will teach you how to read CT head. Fine. Yeah, are you all ready? If you have adequate internet facility, then you can open it. Otherwise, just you can watch it. It's fine, totally fine. Yeah. The first thing is start from the vertex. This is, you can start from base of skull to above also, but it's better to start from vertex. I'll tell you the positions primarily. The first part, this is anterior, in front. This is posterior. This is the right, and this is left. Yeah, counterintuitive. We must look as if we are seeing from the feet side, the feet side of the patient. So if I'm seeing from the feet side of patient, then this is right, this is left. Yeah, which has been marked here also. Now, going by it, start from the vertex and scroll down. It's always better to start from the vertex because you can appreciate the midline shift easily. This is Fox cerebri, right? This is the Fox cerebri. Are you able to appreciate? Please put a thumbs up. Yeah, this Fox cerebri is in the midline. So if there's any midline shift, there'll be curving of this Fox cerebri, either to the left or to the right. This midline, either it might go like this or opposite side based on where the pressure is coming from. If the pressure is from here, means it will go to that side. Fine. Yeah. So we will be appreciating midline shift earlier itself. Then find this omega sign, reverse omega sign. So this is our central sulcus. We found out. Yeah, it's here. Then what you need to do is do a general scroll. This is the first thing. Do a general scroll from the vertex. General scroll. Try to identify any gross abnormality. Fine. If you are able to appreciate any big change, even I would say a layman, even layman can identify something is wrong here, something very intriguing or interesting here. So if for to appreciate it, you need to make a 1 to 2 general scrolls like this, up and down the whole brain tissue. Fine. I am unable to see any gross changes. Hmm? So here from midline, you can see this could be some bleeding or something, but this is calcification of Fox cerebri. Fine, you got it? Calcification of Fox cerebri. As you go more down, lateral ventricles, pineal gland, and choroid plexus. Here you can start seeing the tentorium cerebri. Go more down. Yeah, this is complete tentorium cerebri. Again, if you go above and start seeing the midbrain, yeah, midbrain. Yeah. So midbrain here, Mickey Mouse, cerebral peduncles. Go more down, pons. Here there must be basilar artery, but here In the DICOM file, it's not mentioned, it's not given here. Go further down, medulla would be there. This is showing only the brain system. They have digitally removed all the other bones. So normal CT, I can show you here. It's really good. Yeah, I'm using this DICOM because I need to. I will show you the windowing. Okay, can anyone type down what's the blood window? Just the width and level which I gave you. I know the windows, but just for your practice, just to be keep it a bit more interactive. Just provide me with the width and level of the blood window. It will be in your notes. Yeah, you can even unmute yourself and ask and answer it. No, 70 width. No, 70 width is too narrow. Yeah. So blood width is it's somewhere around 200. Level is somewhere around 80. Yeah. Blood was 80 ounce per unit. Blood level. Yeah. Blood ounce per unit is 80. Clotted blood. The level which we'll be using is 80, and the width is, let's say, somewhere around 180 to 200. Fine. So let me change it. I chose this DICOM viewer because it's much more interactive. I sent you the link also so that you can practice with the same. So this is 180 width, and let's keep the level at around 80. Now again, put as general scroll. So you must be able to do ample number of scrolls in CT. You can do it, right? So I'm seeing from the suprasellar system from now. These, as you can see here, right? So this is the middle cerebral artery. You can see, right? I told you it's come from, it goes through the hands of the suprasellar system start, then goes into the sylvian fissure. See, got it? Yeah. So now blood window is over. Next we can go for stroke window. Stroke window is 30-30, somewhere around something like that. That's how I remember it. Is it right? Stroke window 30-30? Yeah, it is. Fine. Without further ado, we can go. So let's keep it around somewhere. Stroke window width is 30, level, let's keep around 30. So here you can see the gray matter is much more white and white matter is much more gray. So here's a technique. So if you are seeing for stroke, if you are seeing in stroke window, try keeping the screen too far or zooming out. This is a trick I learned. So in that way, you will be, how to say, able to appreciate the gray white differentiation much better. See, if I zoom it out better, I can, how to say, differentiate the gray white levels much clearly. Try even keeping your phone away from your face also. It will be easier to appreciate. Try it. So it's much more effective in differentiating gray white areas. Fine. So every in blood in brain window you found no abnormalities. Go to blood window. Blood window you did a thorough scroll. Nothing was there. You went to stroke window, kept it far or zoomed it out. Did a general scroll of the whole brain. Just nothing much to be appreciated here. Bone window. We can go for bone window. Bone window width is I think it's 2000. 2000 width will be there. The level would be shifted. There will be around 500. There will be around 500. It will be around 2000. See, since I told that, how to say, in this DICOM where they have removed the bone parts, we are unable to appreciate it here. But you can appreciate the calcifications here, right? It's a bit less than bone. Fine. You can appreciate the calcifications. These are definitely not blood. You can rule it out also. Fine. You got it? Please put a thumbs up. Again, let me again repeat the procedure process. Let me go to the brain window again. Brain window is somewhere around 130, 70, 30 something. Yeah. Okay, fine. So we are having in brain window. The first things first, go to the vertex and have a general scroll. Look for any gross abnormalities. Thorough scroll. No abnormalities. Then go to blood window. Have a thorough scroll. Then go to stroke window. Keep your screen far from you or zoom it out. Have a thorough scroll. Then finally you go for bone window and have a thorough scroll. Fine. Please put a thumbs up. Okay. Any other responses from other students also? Saloni is much active here. Thank you for your thumbs up, Saloni. Fine. Let's move on. So this was a normal non-contrast CT brain. That's what I wanted to show you. Next one, there were not enough DICOM files, so I stuck to Radiopedia. Fine. Axial. In Radiopedia, unfortunately, there's no windowing option, so we'll be dealing everything with brain window, which is a challenge, but also it's really great. We're having more practice. First, first things first. What is the first step, or what is the preliminary step? Anyone? Please type it down. What is the preliminary step? Okay, fine. Let me move with it. So the preliminary step is to verify the patient details. Let's assume we have verified the patient details. Fine. Now it will be given here. Okay, headache for 2 months. That's it. 60-year-old male, headache for 2 months. This is the history we are having. So let's start from the vertex. Go down, have a thorough scroll, slow scroll. We can have a slow scroll. Let me share you the link. Okay. For the few cases, for subsequent few cases, I'll be sending you the links so you can do it side by side along with me. Fine. Great. Okay. Again, let's go. Fine. Moving down, have a thorough scroll, move up, have a thorough scroll. So we did you find any gross abnormalities? Just put yes or no in the comment section in the chat box. Did you find any gross abnormalities in it? Okay. Can you show again? The link has been provided, Nikita. You can even do it on your want to. For you, okay. Cross, so slow scroll. With practice, you can do it faster also. Fine. Brain is over. Going again to the vertex. Fine. So as far as I can see, there's no gross abnormality because it would have grabbed my attention. You have seen normal brain so far, right? At least I showed you some 4 pictures, I guess. So again, this is a normal brain. However, since we did gross scroll, now it's over. Now we need to do fine scroll. We need to look for, we need to give more time for every image. As you can see, I am unable to appreciate something here. Much darker thing. If we go by the, I would say, whole width 2000 and level 0, then this would be technically R. However, in Radiopedia, they have used a specific narrow window. So, and this is outlier. This is the outlier. So possibly, see, you can see the CSF. CSF is looking much more hazy, like ground glass or something. However, this is much more dark. What could be the reason? This is one of the finding I saw. Okay, this is just an artifact. However, this is an artifact. This should have been a bit more dense, actually, because the patient came with what complaint? Yeah, he has a headache for 2 months. We have, I would say, ruled out all the organic causes, but still we appreciate something here. This is an artifact. Now, if you look here, are you able to see some dense thing here? Able to appreciate it? Please put thumbs up if you are able to appreciate it. Fine. Yeah. So this something denser. So this could be, this calcification is much dense. This dense area is very much similar to this one, soft tissue. Fine. So this could be some soft tissue. So this is a case of fatty fox cerebri with some calcifications. That's it. Yeah. So this is the case of fatty fox cerebri. So there were some, how to say, densities here, as you can see. Okay, this is not bad. Yeah. Here, as you scroll down, there was some dense region here. Yeah. Which just, how to say, went off as you scroll down. So this is somewhere confined to the fox cerebri itself, to the dura mater, at least, you can say. Next image. Link has been put up. Again, by procedure, go to the vertex, have a gross scroll. Now I appreciated something. So I will stop. I will abruptly stop. Okay, fine. I have abruptly stopped. So I looked for something. So can anyone describe this lesion in the chat box, please? This is very easy. Easy description. Just whatever comes to the mind, just say it. I will correct it, definitely. I wish it to be more interactive. I have tested it a lot, but however, deep in my mind, I believe that this will be much more helpful for you if we have a good interactive session now. Anyone? Even unmute and say, or even type it up. Yeah, YouTube people can also type it out. Okay, fine. Let me continue with it. So this is a hyperdense lesion in the left cerebellar. Again, Saloni. So yeah, so you must say what you see. That's it. So it's just a lesion. We are not sure for now whether it's blood or something else. So yeah, you can say hemorrhage, but let's not just go. Let's just not be too, or say, quick with it. We need to first say it's hyperdense. Then we need to get to know and compare with the other Hounsfield scales, etc. So this is a hyperdense lesion. And if you can say, you can even say the landmarks in the right cerebellar hemisphere, and you can say the extent also. Here, there's not much, how to say, extent to be landmarks to be spoken about, because this is cerebellum. Cerebellum in itself is a small place. So you can say a circular hyperdense lesion in the right cerebellar region. If you want to say, you can say at the level of supracellular system. You can say, because you're seeing it this area. This is one of the landmarks, right? So a circular hyperdense lesion in the right cerebellar hemisphere at the level of supracellular system. Ideally, you need to use a bony landmark. But yeah, oh, sorry, I can see it. At the level of midbrain, sorry, you can say it so. At the level of midbrain, or you can say the full extent, starting from midline, sorry, from the midbrain, extending till medulla. This is the midbrain. It's starting here, Mickey Mouse. Go further down. We have reached pons, basilar artery. See, it's going far from pons. This is medulla. It has started to stink. Pons very large. This is basilar artery. Going much down. This is medulla. So it's ending here. Okay. And if you have, how to say, measurements, the DICOM viewer which I showed earlier, right? This has this measurement option. You can do, how to say, search for the, how to say, you can get to know about the length and the width of the lesions. So this is not the case in this one, DICOM viewer of Radiopedia, so it's fine. So fine. So can anyone type it out? Can anyone type it out any of the findings in the chat box? Full finding. Okay. Meanwhile, you are typing out. I also would like to tell about. See, our gross scroll is over. We found out one lesion. We should not stop right there. We need also scroll further and look for any further find changes also. Like, since there is no windowing option, but ideally what you need to do is scroll from vertex, gross scroll. If you found any, describe it, keep it aside, complete the scroll, come again to vertex, use the blood window, again go through it, come back, use the stroke window, keep your screen far, again do a complete scroll, come back, and then finally use a bone window, do a complete scroll and come back. Then, as I told you before, we also need to do fine scrolling, because see, if you would have looked carefully, see, this is not the normal way the ventricles look. Ventricles usually look like, yeah, This is not the way ventricles usually look. So it ventricles usually look like this, right? As far as we have seen in normal brain. But however, here it looks like this. You can see a gross gap here. So you must be suspicious. What's really going on? But if you see carefully, there's one line kind of thing. It's like this. Let me show you again. Are you able to appreciate the line? Please put a thumbs up if you're able to appreciate it. Yeah. So what happened is these ventricles, these two ventricles are actually separated by one wall kind of structure called septum pellucidum. Let me type it out. Septum pellucidum. This septum pellucidum, in some cases, in rare cases, there might be people with some how to say natural variants from normal variations. We have multiple variations in our life, right? So there might be people who might be having some variations where the septum pellucidum is not a single how to say sheet, but it becomes a two sheet structure. Fine, especially in the posterior part. Here it's complete from anterior to posterior. However, especially in the posterior part, there will be opening of the septum pellucidum. So instead of a single line, there are two lines. Fine. So this variation is called cavum verge. So this is one of the uncommon physiological. And this is cerebellar intraparenchymal hemorrhage. This is common pathological. So I covered two of these things in this radio. Let's go to the next one. Sharing you. This one. Yeah, the link has been shared. You can open it, this one. Okay. Shall we start? Yeah. First, we need to go to the vertex. But since the image is starting from slightly below the vertex region, yeah, I'm going to the how to say the cephalic most part, the topmost part, then scrolling down. Do a gross scroll. Done. So I have reached the end of it. But in the end slide, I have observed something. There's no gross abnormality here. So after gross scrolling, we need to do fine scrolling. While fine scrolling, I observed this one. Are you able to appreciate this? Are you able to appreciate it? Please put a thumbs up. Yeah. So what happened is this is a hyperdense middle cerebral artery. So we talked about this in stroke, right? Hyperdense MCA sign, hyperdense middle cerebral artery sign. So this is a case of MCA stroke, ischemic stroke. Now, if you see carefully, now here, you can see that this is fine scrolling time. So I'm doing fine scrolling. Now I'm able to appreciate this is much more dense than this one. Or I should say, this is hypodense. This is hypodense than other white matter structures, right? So there could be some kind of fluid. So because fluid is less dense. So this could be edema. Edema due to this one, middle cerebral artery stroke. Why middle cerebral artery? Because the clear-cut evidence is hyperdense middle cerebral artery sign. Also, this is also involving middle cerebral artery area. This is anterior cerebral artery area, supply area. This is middle cerebral artery supply area. Fine, got it? Now tell me, what kind of edema is this? This is clearly edema because fluid, we can see fluid here. So what kind of edema is this? Okay, don't go by the shortcut, go by the concept. Because vasogenic, there is accentuation of gray white differentiation and loss of gray white differentiation in case of cytotoxic. So what could be this case? Vasogenic or cytotoxic? In the chat box, please. Yeah, absolutely right. Because one thing is there is here you can see there is loss of gray white differentiation. Though you can slightly appreciate the insular ribbon, loss of insular ribbon is not a definitive sign of MCS2. The definitive sign is you are able to see the thrombus by your very own eyes. Then you can see loss of gray white differentiation somewhere here. This is not much of an accentuation. Okay, let's go to the next one. This is another link. Hmm. Yeah. So we have moved to the vertex. Shall we start? Yeah. So let's move down from the calvaria. From the vertex of the calvaria. We are moving down, able to see just do a gross scroll. I'm able to see an abnormality. Can anyone tell me? Can anyone describe the abnormality which you can see? The gross abnormality which I found in this slide. Yeah, it's hypodense lesion, which is irregular. Where is it seen? Where is it seen, friends? Okay, let me attend it out. So, so this hypodense lesion, irregular hypodense lesion, is seen in no. This is occipital region. Temporal is this side, where your ear is. Ear is here. No, not midbrain, not midbrain. We haven't gone there yet. Midbrain, yeah, again, for you, midbrain is not equal to middle part of brain. Midbrain is a separate structure. It's part of something called brain stem. So this brain and spinal cord is connected via some organ. It's called brain stem. This brain stem has the first part as midbrain, or called mesencephalon. Fine? This Mickey Mouse thing. And by the way, Mickey Mouse sign is actually genuinely a term. I'm not making it up. Yeah. So there is hypodense irregular lesion in the parieto-occipital region. This is parietal. Temporal, where the ear is. This is occipital, somewhere between the parietal. Parieto-occipital region. Right parieto-occipital region. If you want to describe, you can describe the extent also. Fine. As we scroll down further, we were able to appreciate a lot of, how to say, accentuated gray white differentiation, right? Okay. Is there anything else which you can see apart from this hypodense finding? Let us do a gross scroll. By this gross scroll, I am unable to find anything significant. So I'm just doing a fine scroll now, giving ample amount of time for each slide. I'm only able to appreciate this. Then now I don't have access for other windows also. So what must I do? Can anyone tell me what must I do? I told you something. Non-contrast CT is quick and cheap. That's why we are doing it. If you have more money, you can do MRI, but you don't have enough money also. So what you can do? Yeah, it's not CT angio. It's called contrast CT. CT angiography is a very similar modality, but not quite exactly. In CT angiography, you only see about the blood vessels, not the brain tissue. But in contrast enhanced CT, your main focus is on brain tissue, which you are enhancing by using contrast dye through the blood vessels. Fine. Now I'm going to contrast enhancement. Vertex going down, cross scroll. I'm seeing this hypodense lesion starting. Now I'm able to appreciate something. Are you able to appreciate something? Can anyone say what is it? This one. Can anyone describe it? Yeah, anyone? Calcification or hypodense? Calcification is not right term to use. It's a hyperdense. It's some hyperdense lesion. So, as I told you, as we use contrast, we are using the term called contrast enhanced CT. Since actually this class is not about CECT today, I never planned for it. But for information, since we are dealing with this, I will tell you. So it is called contrast enhanced CT. So you need to know what really is enhanced in it. So there's something called enhancement. Enhancement. So in enhancement, what you exactly do is you are putting a iodinated contrast dye, which will accentuate the how to say contrast between various structures based on the blood flow. So here there are two types of enhancement. One is homogeneous and next is ring enhancing. These are the two types of enhancement. What you are appreciating here is ring enhancing lesion because it's not completely white, right? There's some dark area in between. Are you able to appreciate it? Please put a thumbs up. Yeah, great to hear. Now, this is the ring enhancing lesion. Yeah. This is a ring enhancing lesion observed in contrast enhanced CT, right? So there are various differential diagnoses for various ring enhancing lesion. However, here we are seeing something called vasogenic edema. I told you say some minutes ago that there is accentuation of gray white differentiation, right? So this is one of it. It looks hypodense. So it could be some kind of CSF for the active blood or water, right? Basically water. So this is vasogenic edema and there is ring enhancing lesion. So ring enhancement means there is blood supply. There is more active blood is going to this area, to this lesion. So what is the one thing that takes up a lot of blood for its survival? Obviously, it is tumor cell. So this is an image depicting vasogenic edema, which is because of this brain tumor, which is seen in the left parieto-occipital region. Sorry, in the right parieto-occipital region. Fine. Any doubt regarding this? Please open up. Or if I could proceed, then please put a thumbs up. I'm definitely more than ready to answer your doubts, unless if you are hungry or tired. My apologies for that again. Now, just 2 to 3 more slides. further. Yeah, this is again. Okay. So I am going to the case. So this is acute loss of consciousness of a 60-year-old male. Fine. Shall we go to CT? Fine. Let's go to CT. I'm going to the vertex. From vertex, I'm doing a gross scroll to look for any abnormality that would hit in my eye. One thing is I'm able to see this one. Are able to appreciate this? Since this is a 60-year-old male, so elderly male, and there's some hyperdense dot over the fox cerebri, most likely this could be a calcified fox cerebri. Elderly guy, poor guy. So the other gross thing which I found right now is, see, it's starting to getting more dark, more hypodense, hypoattenuated, or I should say. So there is hypoattenuation of frontal area, frontal part of the brain, right? Just for my satisfaction, I'm doing a full gross scroll. Again, completed. This is cisterna magna, went too far. Going again, coming up. Yeah, this is the tonsils. Many minutes ago, I told about tonsils, right? Herniation. So these are tonsils. If these herniate, then the cisterna magna, this foramen magnum will completely, I would say, disappear. Will completely filled. Okay. Back to this case. Now, again, I'm getting a large area. Scrolling above, I'm getting large hypodense area in the frontal area of the brain. Fine. So what could be the cause? Let's look for the cause with the help of slow with the help of fine scrolling. I am unable to find anything significantly. However, with our knowledge, we can say that this is this is hypodense, right? So what could be the cause of hypodense? Hypodensity within brain tissue. This is slightly hypodense. So what could be the cause? Everyone, please put it up. YouTube people also, you can put it up. Edema, exactly. So edema is the cause. So is this vasogenic or cytotoxic? Vasogenic. How so? Uh, any any precise answer, please? Yeah, you can explain your answer. You believe in yourself. Last rule, last golden rule. Believe in yourself. If you have any, if you are thinking as vasogenic, explain why vasogenic. If you think it as cytotoxic, why it's cytotoxic? Just tell me. You are so poor that you can't even. Okay, not in that case. Let's say this person is having some kidney problem. You cannot use contrast in kidney failure patients. So what could be the reason? I don't have contrast to even figure out what's this. Most likely, okay, let me come up with the answer. So most likely this is the cytotoxic edema because there is loss of gray white differentiation. You can ask, why are you saying there is loss of gray white differentiation? Because this is gray matter, white matter. Here I'm unable to say anything about that. This is just some hypodense area. That's it. There's no gray matter, white matter demarcation anywhere to be found. So this is a cytotoxic edema, most commonly seen in stroke. So this is a case of bilateral anterior cerebral artery stroke. Okay, why are you going with cerebral artery stroke per se? Because we are having a history of loss of consciousness. Elderly, there's more chance of him to just bleed haphazardly in or having thrombus in his head. It's very common. Growing old is not so fun. Okay. So moving on, I think this is the last one, I guess. Hopefully. Uh, yeah. Again, go to the vertex, gross scroll, have a gloss scroll. Please do with me. It will be much more fun. Now, okay. The first thing I observed is this is the advantage of coming from the vertex. You can straight away say there's a midline shift. You can see here, right? Annotation. So ideally, Fox cerebrae should have come like this, but it has moved. So this is a midline shift towards the right side. Fine. So this is the point number one, which I have in my mind. So point number two, there's a gross hyperdense lesion to the left side of this left side of the cerebrum. Fine. It is how to say expanding from frontal, covering temporal, parietal, and going even to the occipital area of the brain. Are you able to follow up? Please put a thumbs up if you're able to. Oh, great. Okay, amazing. Fine. So here you can appreciate this is point number two. First one was midline shift. Number two was there was some hyperdense lesion extending from frontal across the parietal, across the temporal, parietal, and occipital region. The convexity, the inner side is how to say concave in nature as compared to the brain tissue, right? Now, this is point number two over. Point number three, I am unable to find lateral ventricle here. While I stopped here, I was unable to find my left lateral ventricle. So where did it go? Usually ventricles don't disappear unless there's some magic. So we need to again do a gross scroll further. Let's go down. I'm able to see the septum pellucidum. Are you able to appreciate it? Are you able to appreciate? Please put a thumbs up. Okay, great. Thank you. So this is the septum pellucidum, which is the wall separating the two lateral ventricles. So I'm sure that this is my left lateral ventricle. Fine. Good. So this is point number three. What happened is my left lateral ventricle has shifted into the right hemisphere, right cerebral hemisphere. Fine. This is point number three. Now let's still go down further. These are choroid plexus, absolutely normal. Choroid plexus calcification. Sorry. Yeah. Still going down. Now the problem I am facing is I am unable to find any of the systems. So this is effacement of systems, right? Do you agree with me? There is effacement of systems. I am unable to see or appreciate any of the systems there. Yeah. So this, especially, I am unable to appreciate the supracellular, ambient, and quadrigeminal, etc. So somewhere in the middle. If I take coronal, just to show you, actually we can just go with this also, but coronal is also necessary. Again, we can confirm with this. Midline shift, left ventricle shifted to the right hemisphere, some hyperdense lesion across the left side of the brain, extraaxial. Yeah, you can also say extraaxial here also. Not within the brain tissue, right? It's around. So extraaxial lesion going down. See, this whole brain parenchyma, there should have been cisterns here, but there's nothing here. So what happened means some brain tissue had closed it up. So closing of this basal system of this cistern effacement is seen in what? Question mark. Is seen in what pathology or in what observation? What do you infer from it? Again, go back to the concept of Monroe-Kelly doctrine. Skull is a very, how to say, strong cavity. So if there is any increase in something, here there is increase in blood, actually. Yeah, I revealed it. Sorry for that. So there is increase in blood here. So the CSF volume and brain tissue volume must be compensated. So there is movement of the brain tissue. This is called brain herniation. So what exactly is this? What type of brain herniation is this? This is transtentorial herniation, because I told you cistern effacement. You can check over the chat box. I have typed it up above, right? You can scroll it up. So cistern effacement is seen in transtentorial herniation, right? Usually the interpeduncular, ambient, and quadrigeminal cisterns. If you want to make a confirmation, go to coronal section. You can also do it here. Okay. You can save this link actually, because it also shows Karnahan notch, I guess. Yeah, it's showing durate hemorrhages. Yeah, durate hemorrhages. Yeah, you can see here. Are you able to appreciate it? It's very hard to find out. This is actually not for how to say UGs to figure it out, or otherwise it's for quizzes to figure it out. This is something called durate hemorrhage seen in herniation. So please read about Karnahan notch and durate hemorrhage. Let me type it out here. Yeah. So this is over. So this is the case of, we will be telling all the diagnosis for each of these, right? So this is banana shape or crescent shape. So this is a subdural hemorrhage. Subdural hemorrhage in the left hemisphere, left cerebral hemisphere. Sorry, around left cerebral hemisphere. Sorry, it's extraaxial, right? Yeah. Next, with, so this subdural hemisphere has caused midline shift, as we can see by the Fox cerebri shift, as well as ventricular shift. Then last one is, this subdural hemorrhage has also caused transtentorial herniation. So that's the conclusion. So what we can infer from it is, yeah. So this is the left subdural hemorrhage with midline shift towards right, and left uncal herniation. Uncal herniation is, or other name is lateral transtentorial. Fine. How much is there? Okay, I told you about meningioma, so we can skip it. The same image I am giving here. This is the last. This is just for quizzes. This is just for fun. So what? This is the fun question. Actually, this is very rare congenital condition. Can anyone type what you can see, what you can appreciate, or to be precise, what you cannot appreciate? There is something very odd from how to say normal brain. Absolutely odd. Yeah, can anyone list out everything which you can see? Everything, as in whatever comes to your mind. Just brainstorm it. This is actually a really good thing. I just wanted to show it to you. This is rare, but again, I told you, this is for quizzers, enthusiastic people. Fine. So let me reveal the secret. Usually, normal brain, we will have sulci and gyri. So which is that depressions and the foldings. Brain cortex has folds. However, here you can see it's as smooth as a pebble, right? It's completely smooth. There's no, how to say, sulci, and there's no appreciation of gyri. So this condition is called lissencephaly. This is very rare. Again, I told you. You can just, let's say, boast off with your friends by getting to know this encephaly. Yeah. So this appearance is characteristically called figure of eight appearance. Let me annotate it so that you can learn about it. See, this looks like figure of 8, right? Or at least for the radiologist, it look like that. So this is figure of 8. Appearance, seen in lissencephaly. It also has hydrocephalus here. You can see hydrocephalus here. Hydrocephalus means it's just a, how to say, ventricles have become big. That's it, due to CSF fluid overload. I guess that's pretty much it. Thank you very much for sitting with me for so long. Who all didn't have dinner yet? I hope everyone had dinner. Please raise your hand. Actually, I'm feeling really sorry for keeping you all here. You have been a wonderful audience. Even 15 participants have made by day. Thank you very much. We had spent 7:30 to 8:30, 10:30, 3.5 hours. Oh, Swayam. Okay. Okay. Happy dinner time, Swayam. I'm really sorry. So, just we need to have a group picture. That's it. So, I'm so sorry for keeping you people. Did you love this session? Could you please just put up a feedback in chat box so that I can just have a good sleep tonight? I don't want to carry on the guilt of just keeping you awake for 3.5 hours. I planned it a lot actually. However, due to some DICOM problems, I removed and completely replaced with Radiopedia. Yeah. So, so these were the standard books which I used just for simple references. So the first one is Osborne's Brain. So Osborne's Brain is one of the, how to say, very famous and gold standard books. The images are very good, excellent images in this. Next one, as we use today, Radiopedia. It's a good website. And this is, I used it for module 1 also. This is basic radiology by Lang publication. And yeah, let me share you a link here actually. So please don't share with many of the people. I'll just share only to 15 people of yours. Okay, fine. I won't even utter it, so even the YouTube people can't hear this. Fine. Wait a minute. How many people are watching it? 3 are watching now. Fine. Let them also learn. Fine. CT Head Comic by Radiopedia. So I'll show you here. CT Head Comic. So if you are bored and if you want to yet learn, so CT Radiopedia has a head CT graphic novel comic kind of thing. So you can use this one. I'll share the link here also. Fine. Yeah. So I'll be right now sharing the feedback form. So this is our module 3, which has been proposed by me. So this is eFast. eFast is like ultrasound which we use in emergency situation to look for sudden bleeding or sudden rupture of solid organs, etc. So catch you all on in module 3. Can you fill the feedback form later? I will send now. You just copy and keep it somewhere in your WhatsApp or something. Fine. Let me share you the feedback form. In YouTube also, I'll just put it up right now. Fine. And these are my contacts, contact detail, email address, Instagram, and my LinkedIn. You can go for it too. And yeah, thank you.